So this is the Concept Academy. I'm Festus. I'm going to be unraveling the mystery behind cardiovascular system step 2 for you. Though I won't be able to finish it, but anywhere we are going to get to, I will try to show you what you want to take into the exam. And by God's grace, you will see the magic. The thing about the step 2 basically is that most of the materials that fly around, don't be deceived. So they hardly bring out questions from them. You can only pick 1 or 2 points in them. So the main material that will help you for the exam is still the first aid. Very well, because it's packed. Everything is packed in them. In it, all you need is to sit down and revise those points over and over again. In fact, when you see the question, you'll be able to know that this is actually what the question is all about without you overthinking it. Then for the clinical practice too, you need a material that can help you to have a clinical based knowledge. Yes, solving questions is actually good, but you are not going to be solving questions when you see the patient. You will be demonstrating knowledge. That's why you need to move closer to your first aid. If you are good, you are good. US is not Africa, where people they can overlook all manner of stuff. If you are not good, you are not good. All right. So after this cardio, whatsoever we show you in cardio, by God's grace, by next week Thursday, we'll pick another system again. No, this week. Saturday too, we'll pick another system. We'll just show you the basic points there. We may not finish them, but at least whatsoever you are going to get during those times is going to help you a lot. We also have already produced material that some people have subscribed into. So by February, we'll do a live class. The difference between what we'll do today and the live class that will be starting in February is that the one in February will solve all manner of questions. This one will just make the point and go. All right, sit back, get yourself a cup of coffee while you enjoy what we have for you. Thank you. So this is actually the summary of what you want to take into the exam: ECG, cardiac physical examination, arrhythmia, cardiac life support, basic congestive heart failure, and the likes. So you can see. So with respect to the ECG, what do you want to take into the exam? We have a way of looking at ECG basically, but you don't really need that. So you don't need to go into the exam and be checking is there P wave? What is the QRS complex like? You don't have that time. So there will definitely be a condition that they are trying to bring out of. They want you to diagnose. They will and that condition is going to jump at you. The ECG they give in the exam, they are not difficult ECG. They are just simple ECG. But because it is called step 2, many people think that it's actually all this complex ECG that they are trying to give. So you can easily predict, even if you don't know the ECG, you can check the option and be like, I just hope it's not this option C, because it's easy. You just pick it and you realize that they mark it and they say you are correct. So that's just to first of all make you to be relaxed that it's not something that is quite much they will be given in the exam. The heart rate, this is just for your own information. You are not going to the exam to be calculating heart rate per se for them, but you may calculate it for your own sake to know whether the patient is bradycardic or the patient is tachycardic. All right, when you open your first aid and you see them put key fact there, what it means is that take it into the exam. You will never regret it. It's either they've tested it before or you will need it inside that examination. When you open your first aid and you see key facts, so if you know you are going for your exam next week, you can as well open your first aid and flip through all the key facts. You have all the facts. You call them facts, cardiology facts, to take into the exam. You will see the way I'm going to be showing you the key facts. So the heart rate is 300 divided by the total number of large boxes. So you just look at the QRS complexes you have here. How many large boxes can you see here? This is basically 3.5. So 300 divided by 3.5, you have an idea of what the heart rate is. Most especially if you are dealing with regular heart rate. Regular ECG. So this is the rate. The normal rate, everybody here knows the normal rate is 60 to 100. So when you get into exam and you are seeing the heart rate given is less than 60, just this is bradycardia. Once it's greater than 100, you say this is tachycardia. The common causes of sinus bradycardia, there are quite many. If I say we should list them now, everybody will list them. In fact, I'm very sure you will be saying sick sinus syndrome, the drugs, vasovagal attack, beta blockers, keep naming them. Then acute MI that is affecting the right coronary artery and the likes. Raise intracranial pressure. Yeah, but there is one they will test in the exam. And that's this physical fitness. So when you get into the exam, you see them give, they will just say this is year-old patient that is having the heart rate of maybe 55. The patient is okay, is fine, and different kind of thing. Maybe you are dealing with someone that is building weight, or this kind of people that gym a lot and the like. So physical fitness can make a patient to have sinus bradycardia. They know you will be thinking towards a pathology, but there is no pathology in this patient. So before you start writing expensive investigation for that person in US, when the patient does not need one. What about the causes of sinus tachycardia, anxiety, anemia, and the likes? So they are all there, you know them. If I say you should list them, you will list all manner of stuff, thyrotoxicosis, so they are not big stuff for you. And you are done with that. What about the reading? Basically, we have what we call the sinus reading. What does it mean? For every QRS complex you will see a preceding P wave. That's just the sinus reading. All right, so that's just by the way. So if I thought you still see something that look like this, and the patient is having arrhythmia, you call this sinus arrhythmia. So it shows that arrhythmia is coming from above, likely from the SA node. All right, so what about the ASIS? USMLE hardly test ASIS in the exam. They hardly test it. So baby, for information's sake, so that first aid will not be written without mentioning ASIS, so they just need to bring it out. So we have the normal ASIS, we have the left ASIS deviation, we have the right ASIS deviation, we have the extreme. All right, you can look at the left ASIS deviation and just think towards something related to the left. Left anterior hemiblock, left ventricular hypertrophy, and the likes. Right ASIS deviation, you can think towards something related to the right ventricular hypertrophy, anterolateral hemi, and the likes. Left posterior hemiblock can also give that, but they hardly test it. So what I'm trying to say is that when you are going into the exam and you're like, someone is mentioning, do you know your ASIS deviation? So they hardly test. So I'm not even expecting them to ask any question on it in the exam. All right. So you come down to the interval. We have what we call the PR interval. You can't go into the exam and forget the PR interval. In fact, even if you forgive yourself, no one will forgive you. They will test this one like anything. The prolonged PR interval, the short PR interval. What is happening in prolonged PR interval? So you just see, usually see this in first degree AV block or heart block. So you look at the PR interval is going to be shortened in a condition called Wolff-Parkinson-White syndrome. You can't forget this. There is one comment there. He say Wolff Parkinson White syndrome. You don't want to forget it, because these are the ECG they give. You can predict the ECG they will give in the exam. All right, so that's just by the way. PR interval is prolonged. I will show you the ECG. So you think it was something like first degree heart block, and what is causing it to be prolonged is actually delayed AV conduction. You remember AV node? So there should be a conduction tree to come to the ventricles. So if at all is delayed, then you are going to be seeing the PR interval is going to be prolonged. All right. There are some drugs too that can make the PR interval to be prolonged. Beta blocker, not dihydropyridine, calcium channel blockers. They can all make the PR interval to be prolonged. What's the normal PR interval for crying out loud? Normal should be 3 to 5 small boxes. So you now check the PR interval that is given to you. You realize that it's actually more than 3 to 5, then it's prolonged. If it's shortened, it's less than 3 to 5, then it's short. So these are the two. You just ask your friend when you are in your tutorial, like, what is the cause of the prolonged PR interval? Mention the drug beta blocker, not dihydropyridine, calcium channel blocker, first degree heart block. Short, what don't you want to forget? Wolff Parkinson White. I'll show you everything you need to know under the Wolff Parkinson White for the exam. Everything, then you can predict your question from them. Then look at the QRS interval. So QRS interval, the normal one should be less than 120 milliseconds. Then you have some stuff you can make reference to with respect to the QRS interval or QRS complex. Okay, what are those things you can diagnose from it? The first one is left bundle branch block. So you can just look at the QRS in the exam and say, this is left bundle branch block. This is right. So just look at the QRS complex that is given. So I will just quickly show you the left bundle branch block, how it's going to look. So this is the left bundle branch block. So you can see it. I just want you to look at this V1, V2, V3, V4, V5. These are the precordial leads. So just look at the V5 and V6. Can you see? Look at this QRS. Can you see how it looks? Can you see? Look at this place too. Can you see the way it looks? So this notch that you are seeing, that's what we give it out in the exam. So they have a particular mnemonic that they normally use to just show you how to remember it. We call it Williams. So you don't need to cram, just for you to have an idea of how it looks anyway. So you just see that notch, M shape. You can see the M shape. Once you see something like, just say this is left bundle branch block. All right, now that's left. So what do you want to take into the exam apart from the shape? So anytime they give it to you in the exam, what they are most likely going to test is MI, acute MI. So you read a question, blah, 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 this also patient have this, and that, and ECG is showing left bundle branch block, and it is, just say, okay, what do you think this patient is most likely having? Just check through the options and pick MI. Most likely. It's not on its own saying that once you see it, you just say MI. But there are some other stuff in the ECG that you don't even want to be bothering yourself on that are most likely going to give the patient the MI. All right. Those other things is what we put together in a wonderful, well-decorated criteria. You call it Gaboza criteria. Gaboza criteria. So when you see it, you can easily say that, okay, this patient with this left bundle branch block I'm seeing, and this patient is most likely having MI, acute MI. Now, you don't need to cram this for the exam. You don't need it. You don't need to come and cram concordant ST elevation, concordant ST depression. You don't need to cram it. But when you read your question, you are saying left bundle branch block, most likely that question is revolving around acute MI. Then I'll say, how do you know? Now say there is a criteria that will bring it together, that will bring in some other features that I'm supposed to look for in the ECG. But I'm very sure this question is most likely related to the acute MI. Very easy and straightforward. In the exam I'm talking about, that's what we help out. So no story. Just look and when you see it, just be like, okay, this is most likely Akitemi. The question is all about. And miss all the options. Any option you see that justifies Akitemi, that's your answer. All right. So that's that about this area. So you can see key fact again. Smith modify Garbosa criteria. It doesn't mean you will go into the exam to be to be using it. I just put something here that I must know. So it's a must know, but if I thought you can't cram this, but don't bother. Don't be too anxious. You don't really need to cram it. But just remember left bundle branch block. What about the right bundle branch block? What are we going to see? Right, rabbit. Yeah. All right. Rabbit hair, we say. Let me show you the rabbit hair. How rabbit hair look like. What did I? Rabbit hair. So this is rabbit hair. Can you see? Can you see the way it looks? Can you see rabbit hair? Can you see? So now let me come back to the page and try to draw it for you. So you have something like this. Rabbit hair. So if I do this now, I just put something here, you'll be like, Festus, are you trying to draw a rabbit? All right. So that is what you will see in the ECG. So you just see something like this. You see something like this. Here, can you see? You see something like this. Rabbit hair. Immediately you see this, just be like, this is looking more like right bundle branch block. All right. That's just by the way. Okay, there are some other conditions too. You could have seen this, but don't be bothered. Once you see that, just say that this right bundle branch block. When I get to some area, I will emphasize this right bundle branch block again. We are done with that. Come down to the QT interval. Whatsoever they are going to ask on the QT interval, you already know them, and I will try to mention some of them for us. The normal QT, corrected QT, is supposed to be 380 to 440. Now, you need to put that at the back of your mind. So you come down to this place, just like, Sheung or Precious. What's the normal QT interval? You say it's 380 to 440. That's more than enough. So if I thought they give you a QT interval in the exam that is 480, you already know it's prolonged. That's that. Just this is prolonged. So you can't go into the exam and say you don't know the number 380 to 440 milliseconds. So they are most likely going to give you because it's just 1 hour plus, most likely going to give you the value. So you just look at it and say, is it prolonged or not? So it's definitely going to be prolonged until proven otherwise. If at all it's not going to be prolonged, well, you will know. So what are those things that can make it to be prolonged? Electrolyte abnormality, hypokalemia, hypocalcemia, hypomagnesemia. Hypo is hypo. So what is the headache there? Hypo. All right. There are some medications too that can make them to be prolonged. You remember A, B, C, D, E, F, N, O. So in step 1, so A, B, C, D, E, F, N, O. So antiarrhythmic drug, 1A, class 3, antibiotic, antipsychotic, antidepressant, antiemetic like ondansetron, antifungal like fluconazole, Navea, and opioid. So they may just tell you that the patient is taking maybe a particular antibiotic, like this patient is having this so condition. Then they now give you the QT interval, and they now tell you, they give you the value. You're already thinking towards prolonged. You just see something there that will tell you that this patient is taking a particular drug. It might even just be anti-emetic. Maybe the patient recently had something that warrants the patient to take anti-emetic, maybe chemotherapy or something, and the patient is taking ondansetron. You now say, what do you think could be responsible for whatsoever the patient is having? Your answer will be medication adverse effects. All right. It may be fluconazole that they will be testing in the exam. It might even be chloroquine. It might be fluoroquinolone, like this patient is having urinary tract infection, taking a particular fluoroquinolone, and now say the patient is now having this also condition, the QTC is discovered to be prolonged. Now say, what do you think is likely causing this? The answer is medication adverse effect. That's why A, B, C, D, E, F, N, O is very important. It might even be opioid. How will you know it's opioid? You say they brought in the patient, the pupils, they are actually constricted, pinpoint pupils. The patient is having some depression, respiratory depression, and the likes. So you just check it. Maybe you see that pinpoint pupil, you know that it's opioid this patient most likely has taken. And then also, what do you think is likely responsible for the cardiovascular or the findings on the ECG? The answer is going to be substance abuse, something like that. All right, so that's how they are most likely going to test this. I put a big arrow here because everything they've given here is very important for the exam. All right, so that's just by the way. There are some conditions where you have congenital causes of lung QT. How will you know this is congenital? The patient is definitely going to be a small patient when we use that thinking towards congenital. If not someone that is maybe 1 year old, 6 months, having this, and just small patient like that, or two, just like in that pediatric age group, that you are not expecting to be having the prolonged QT. So you now see, immediately you see the age and you're seeing prolonged QT in the question, you start suspecting that this is most likely going to be congenital cause of long QT syndrome. So the next thing you are checking for in the question is any hearing impairment, or is there no hearing impairment? If there is hearing impairment, sorry, if there is hearing impairment like sensorineural hearing loss, you'll be thinking towards Javan and Lange-Nielsen syndrome. If there is no hearing impairment, you will be thinking towards Romano-Ward syndrome. Okay, how will I remember? Because this one is sounding like no word, no. When I say Romano-Ward, say Festus. Hey, wait, Festus. I hear a word. I hear word. Say word. Oh, so you actually had something. Word. You could hear the word there. So that's Romano-Ward. That one does not have what do you call it? Does not have hearing impairment. So however, this one that you can't hear any word in it, so this one most likely come with hearing impairment. All right, so that's just how you will be, just that single point you will be looking for in the exam, and you are okay. All the others, they are just notes. Then you come down to ischemia and infarction. So we have what we call the acute ischemia. So basically, what you want to focus on in the exam, whether in the story they are going to give or the ECG they are going to give, hardly. So it's just the Q wave basically around this area. Apart from Q wave, you can also check or focus on the ST segment, what is happening to it. So but never forget the Q wave at all, just for you to know what kind of ischemia I'm dealing with. All right, so this is actually the Q wave. This is Q wave. You can see Q wave. You can see Q wave. Festus, why did you put a line here? All right, if it's acute, you can see the Q wave is already coming up here. Around this, within 24 hours, you can see the Q wave is already coming up here. Can you see? That's Q wave. Then, if this patient has had it before, maybe the ischemia has occurred before, and this patient is now looking stable now. This is a stable patient that you are just doing ECG for, and you are now seeing this Q wave that is quite deep. So you start suspecting maybe previous MI or chronic MI. So that's just what you want to take into the exam. The story is most likely going to guide you. This is someone that they are just doing, coming for routine examination, no complaint, nothing, blah, 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 and the likes. They do ECG and they are picking this Q wave. What does it suggest? Previous myocardial infarction or something. That's just what you want to take into the exam. Because if you look at this ECG, apart from this Q wave, there is really nothing. Sorry. That is looking quite abnormal here. So please just note the Q wave in the exam. There are some ECG that you are supposed to see Q wave normally, but please note this very, very well. So Q wave signifies either acute or previous ischemic event. That's what you are taking into the exam. So the question is likely to be in words and mention it Q wave on the ECG. They will mention it. Now be like, it's either I'm dealing with acute event or previous. Is this patient symptomatic? This patient is not symptomatic. Likely the Q wave you are seeing there is giving me an impression that the patient previously had ischemic effects. All right. So what kind of ischemic effect will you be thinking about? Most likely STEMI. ST, segment elevation, myocardial infarction. STEMI. All right. The one that is non-Q wave, in fact, is most likely going to give STEMI. Sorry. Can you all, are you with me? Are you hearing me? Or I've been talking to myself?
Yeah, we can hear you, sir.
We can hear you.
Can hear you, sir.
All right. To those people that are sleeping, sleep well. We'll wake you up when we are done. All right. So that's just by the way. If you look at it, it's not even something that is difficult. So you just want to relieve yourself, because most of the questions you are solving around, they are not USMLE standard question in a way, because when you get into your exam, you may be disappointed. So you just want to lighten your head and think simply, so that when you read the complex question, you be like, I hope this question is not. That's the beautiful thing about the first aid. First aid is a summary of whatsoever you are going to see in AMBOSS. So first aid is actually produced from AMBOSS. I just need to say that I may be wrong, so that no one is going to hold that against me. But if you take AMBOSS and take first aid, the mnemonics you see in AMBOSS is what you will see in first aid. They may now change one or two words there, so it's the same thing. So if you are reading your first aid, you are combining so many books together, but you don't know. All right, so that's just by the way. There is something I try to highlight for us here, and that is, in a normal ECG, R wave increase in size compared to the S wave. Usually, when you look at V1 and V5, so you see the R wave in V1 will be smaller compared to the V5, which is going to be larger. All right. So when you do not really see that progression the way you should see it, say poor R wave progression. So that's just by the way. Just for you to put that at the back of your mind, it can actually be a sign of new or prior anterior infarction. So that's just by the way. But in the exam, you are not going to be looking at R wave progression. They are just whole story here. So you are most likely not going to be looking at that. So what about the chamber enlargement? The chambers, we are going to first of all focus on the atrial enlargement, the right and the left. So when you pronounce right atrial enlargement, both of them, they're actually related to the P wave, basically. They are related to the P wave. All right. So if you pronounce right atrial enlargement, something should come out. Height, right. Height. So P wave here, we gain height. So when you look at the question and you see P wave is now very tall, this is just right atrial enlargement. So most likely that's all you need. So you check the question, the ECG that is giving, and the P wave that they are giving to you has gained length. So it's going to be wider. So the duration you are going to be seeing it is going to be more than 120 milliseconds. So if you are seeing something like I said, left atrial enlargement, now relax. Festus, this is becoming too much. Sincerely speaking, you don't need most of all these clinchers, because the story they will give is most likely going to give it out. They don't just give ECG and just say what's the diagnosis. They will always give you a story. That's why we merge everything together. So sometimes you don't need the ECG. Sometimes you don't need the echo. just by reading the story, looking at the blood pressure and the like, you can predict what the patient is having even before some stuffs are done. So relax yourself. If you can understand how the right atrial enlargement is most likely going to present, to the left atrial enlargement is most likely to present, you can easily look at the ECG that is given to you and be like, okay, they are actually in tandem. So this is left ventricular hypertrophy. Basically, I feel that there is no way they will give left ventricular hypertrophy and you will say, I don't think this is hypertrophy. What will you say you are thinking about? Because you look at the hard wave, you look at the S wave, you can see all manner of tallness, depth, and the likes in them. You know, you are going to be like, okay, this is looking more like what do you call it? This is looking more like left ventricular hypertrophy. So I put something here: CIF first, reverse 5. CIF. Don't mind my pronunciation. CIF first, reverse 5. So SV1, RV5. So when you look at this, you see that's S wave in V1, R wave in V5. So when you add two of them together in that ECG, you are getting like 45 and beyond. So you'll be thinking more towards left ventricular hypertrophy. But I bet it with you, you are most likely not to be tested on it. Most likely not to be tested on it. So, but just for you to note, and if I thought they give it to you, you've forgotten the formula that you don't want to give yourself headache about, just look at the ECG. When you start seeing all manner of depth, all manner of tallness, and like, you'll be like, I hope this patient is not having left ventricular hypertrophy. You also have some other criteria that I will not advise you to give yourself headache on, basically. So, but that's fine. Now, they give you the ECG. Just see the ECG. You're like, the way these waves are, I hope this patient is not having left ventricular hypertrophy. You've not even calculated any, but that's just your impression. They now say, what do you think is the most likely cause? This is what USMLE you are going to write with test: hypertension. You see this aortic stenosis, less than 5% probability that's what they will test. All these ones, they are most likely not going to test them. It is this hypertension they are going to test. Hypertension is actually of public health significance. So many people have hypertension that they do not know. So even if you disregard it, it has killed so many people. It can cause a lot of problem. So if I thought they are going to drive something into our mind as you are going for the exam, it is the significance of hypertension. That when you see a patient with hypertension, you don't overlook it. It's a psychological question. How can you say you prepare for step 2 and step 3? And you now get here, you are now like, it's not important. That's the one they will test. I bet it with you. In the exam, this is what they are most likely going to test. First aid is very precise. It's the most common that they are going to test. When you check your AMBOS, it's still the same thing you will see. But these are the orders. That when you check the question, you don't see that hypertension, which is not likely. You can be thinking towards these other ones. How will this play out? Young patient, coming, no symptoms, nothing, is now having left ventricular hypertrophy. After you just say, what do you think is likely to be the cause? Just say, hypertension. Go and check that patient for hypertension. So what is now causing the hypertension, we may not know until proven otherwise. So it may be some endocrine problem, a renal problem, and the like, but just pick hypertension. I'm quite specific like this so that the main thing themselves, you take them into the exam without you overreading jargons. All right. So, axis deviation can be a sign of ventricular enlargement. So, the question is most likely going to be in what they will just mention. Left axis deviation is seen when they did the ECG, blah, 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 and the likes. Okay. What do you think this patient is likely having? Ventricular enlargement. So, if that is the case that you are saying, if that is the case of the question they are giving, so the other stuff they may be asking may actually be related to hypertension. So this is right ventricular hypertrophy 2. So R wave in Phi1 is greater than 7 mm. So what you see here causes pulmonary hypertension, pulmonary embolism, chronic lung disease, mitral stenosis, and the like. So something just related to the right heart and also the lung. So you already have an idea what can make the right ventricle to start becoming thickened. So either the blood cannot go out, there is hypertension, there is chronic lung disease called pulmonary blah 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 and the likes. So that's that. All right. We come down to cardiac physical examination. So what do you want to take into the exam? The first thing is jugular venous distension. The advantage of whatsoever I'm going to say here is because the story you will read will mention jugular venous distension. Jugular vein is more or less like a, how do I want to put it? Like more or less like a signal that gives you an idea of whatsoever that is going on between the right atrium, right ventricle, and also the venous drainage, like the inferior vena cava, the superior vena cava. So when you look at them, they should empty into a place. That's the right atrium. So if the blood is not going down the way it should go from the right atrium to the right ventricle, then the jugular vein is going to, the pressure in it or the height of it, the distension, you are going to start seeing distension in it. The pressure is going to be high. All right. So it shows that the blood that is going into the right atrium is not going forward. So that's what it means. So if you read any question in the exam, you now see jugular venous distension. Most likely the blood in the right atrium is not really going forward. What could have caused it? Maybe we are dealing with right heart failure. Maybe we are dealing with pulmonary hypertension, because with hypertension, enough blood cannot leave the right ventricle into the pulmonary vessel. So that's just by the way, just for you to have an idea of when you see this in the exam, what you can be thinking about. What about the significance of hepatojugular reflux? They will mention it in the exam or they say something about it. The way it is this. It's just a signal too. It's also a signal. You will see they will portray a patient with edema for you. That edema, you are not sure where that edema is coming from. Is it from the liver? Is it from the heart? Hepatojugular reflux will differentiate them in the exam. This is the reflux you want to use to. So the question must talk about edema. Maybe we should call it edema question, Abby. Yeah, you can give it that name if you wish. You just want to use it to different. I'm seeing edema in this. Is this from heart failure? Is it from liver problem? You don't know. They will now do the hepatojugular reflux. Let me show you how it's going to be done. You can check. I don't have that luxury of time. I will have go online to bring out a video on it for you. So look at the liver. This patient is already having edema, blah, 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 and the likes. So they are going to apply pressure here. So when they apply pressure, so if the pressure can be transmitted through the liver to the hepatic vein, to the inferior vena cava, come to the heart, it's more or less pushing blood into it. So you will see a surge in the, jugular venous. So there will now be a jugular venous distension, just a surge. So it shows that whatsoever that, it shows that the liver does not have problem in a way. That's what it means. It shows that liver does not have problem. Why did I say so? Because when I apply a pressure here, if the liver is cirrhotic in nature, the pressure cannot even be transmitted through it. All those vessels have been squeezed off. So they've been squeezed off. So pressure cannot easily transmit itself through the liver. So you won't see this jugular venous distension. You won't see it if the liver is having issue. So for me to apply the pressure and I'm seeing the jugular venous distension, then the liver is looking okay. Most likely that edema is coming from the heart. The question says they try to apply a firm pressure on the liver and they are not seeing anything. That edema is coming from the liver cirrhosis. That's all. That's just what you want to use to the hepatojugular reflux to do in this exam that you want to write. All right, so that's just by the way. That's that the Kussmaul sign. So you can see this. You're also having increase in jugular venous pressure too. So with inspiration, what is happening here? Normally with inspiration, the intrathoracic pressure should reduce. So that will draw blood into the heart, and that will also, or towards the lung, that will, or you say, draw blood into the thorax and also bring in air. So it's going to bring the two of them into close proximity for gaseous exchange. Is that not what happens during inspiration? That's it. So now what we notice is that if, let me draw a simple diagram. If this is the heart, so the blood is coming in here. During inspiration, it should flow towards the lung. So the pressure within the right atrium should actually reduce, like it should fall, so that blood can move forward. Then more blood can come in and move forward and go towards the lung. This is the lung. All right, this is the lung. All right, that's what you should see. But with Kussmaul sign, all we notice is that the blood cannot easily empty itself into this right atrium, and if at all it empties, it cannot really go forward in a way. All right, so if that is the case, you are going to see with inspiration, you will now be seeing raised jugular venous pressure. So it shows that the blood is not really going forward the way it should. So, sorry. So we have so many courses they can test in the exam. One of them is actually constrictive pericarditis. All right. So USMLE first aid, first of all, specifically mention constrictive pericarditis. What does that one mean in the exam when they mention Kussmaul sign? Amidst others, just be very sure. Hope this question is not about constrictive pericarditis. It's just as easy as that. So just be, hope this question is not about constrictive pericarditis. All right, what about the systolic diastolic murmur? Now, before I go to, murmur, let me come down to the murmur. Murmur, there is a way you look at the murmur in the exam. You want to separate mitral valve prolapse and hypertrophic cardiomyopathy from other types of murmur. All right, so these ones, you look at them separately. Let us first of all look at them before we look at the other forms of the murmur. Mitral valve prolapse, hypertrophic cardiomyopathy, these guys, they are different in a way. So if there is increase in the blood flow to the heart, then this murmur here, they are most likely going to reduce in intensity. If there is reduction in the blood flow to the heart, this murmur, they are most likely going to increase. Now, relax. These guys, if you look at the other murmur, when there is increased blood flow to the heart, they will increase. When there is reduced blood flow to the heart, they will reduce. Increase, decrease for the others. When you now start reading the question and you analyze that question, you now realize that with this condition, there will be reduced blood flow to the heart. And the question is saying the murmur increases. Just, you are likely dealing with any of these two guys. So you just see them interchange. Increase blood flow, reduce murmur, or reduce blood flow to the heart, increase murmur. That's all you are looking for in the exam. All right. So let's look at these conditions. These are the maneuvers that can tamper with the blood flow to the heart or the systemic vascular resistance. Now, squatting. When someone is squatting, that person is indirectly squeezing the veins. So most especially around that time, the patient is just, so you will see increase in the venous return. Now, if there is increase in venous return, the more blood is flowing to the heart. The question now says that the murmur they are peaking in the heart reduces, just know you are likely dealing with any of these two. And most time they will just put one of them there. One of them, they will just put it there. If they put two of them there, there is a way you will separate them. All right, I will show you where you will hear this murmur, and I will show you where you are going to hear the mitral valve prolapse murmur. What about the leg raise? So I will start this. What about the leg raise? When you raise the leg up, you are also increasing the venous return. So the question will also say the murmur reduces, increase, decrease. Just know you are dealing with these two guys. When a patient stands, then you will see the venous return will drop. All right, so if it's dropping, the murmur will increase. That's all you want to see. It's just increasing. All these, their stuff here, their story. It's just increase. All right, hand grip. When someone is gripping the hand, so what happens is there will be increase in systemic vascular resistance. All right, so what is happening in systemic vascular resistance? So let me try to show us. This is what is happening here. So if there is increase in systemic vascular resistance, the blood cannot flow out. So it can't flow out. If it can't flow out, the blood that is entering into the heart will now be causing the left ventricle to distend. So when the left ventricle is distending, the obstruction is going to be shifted away. If the obstruction is shifted away, the murmur intensity is going to reduce. So look at it, increase in systemic vascular resistance is also going to cause what? Reduction in the murmur. The arrow is going different direction. All right, look at the inspiration. Inspiration will draw blood into the heart. So there will be increase in venous return to the right heart. So with that one, so what we have here, sorry, 1 minute please. So what we have here is actually increase in the, you need to be very careful here. Now, this is the gist. The inspiration is bringing blood to the right heart, whereas with respect to the left heart, the venous return is actually reduced. The venous return is actually reduced. All right. If the venous return is reduced, MVP, HCM, they are actually related to the left part of the heart. So if they are related to the left part of the heart, what you will see is that the murmur that you are hearing in them will actually increase. So you need to be very careful when you look at the inspiration. But most times they don't go around the inspiration in the exam. So they just focus around these guys. Now, the last thing I'm going to mention is Valsalva maneuver. I know you will have overlooked Valsalva maneuver because of the way it sounds. So yeah, what is it? Is there anything quite significant about it? Clinically and statistically, it's highly significant for USMLE step 2 and 3. And this is the reason why you need to focus on it very well. In fact, when you get here towards the exam, look at it and look at release, strain. They will put two of them amidst the options. One of them will increase the systemic vascular resistance, while the second one is going to reduce the systemic vascular resistance. Okay, let's look at it like this. I don't want to give myself I shall know it's Valsalva maneuver, and I'll say HAR, release, we increase systemic vascular resistance. Then the strain will reduce systemic vascular resistance. So one of them is HAR, high Hess, the other one is Hess, HAR, Hess. So you don't have similar letters following themselves. You don't have similar letters. So another thing mistake you may want to make in the exam is this. You may want to say release is going to reduce systemic vascular resistance. Now, Festus was shouting, no two letters of the same, the same two letters actually follow themselves. So this is going to be wrong. So release is going to increase systemic vascular resistance, while the strain is going to reduce systemic vascular resistance. Use that if you wish. If it doesn't make sense to you, throw it away. All right, so, and you are done with this area. So what about the other murmur? I've already mentioned increased flow, increased murmur. So in the exam, the way they will put it is, and they hear a murmur that increases when there is increase in venous return or something, or inspiration, or once you start reading all those stuff, just know you are most likely dealing with other valvular murmur, and that's that. So you come down to this area. This is more or less about auscultation, but there's a way. What we are going to use to dissect it is what you have in step 1, basically. All right, so this is APT, APT hem, APT, APT hem. So A here is the aortic area, and P here is the pulmonary area or pulmonic area. The T is tricuspid area, and hem is the mitral area. All right, so there is what we call sternal border in the exam. Sternal border in the exam. This area that I decorated like this is actually the sternal border. This is also a sternal border. But most time, all you'll be hearing is left sternal border, left sternal border, left sternal border, left sternal border. So when you hear left sternal border, or you look at the question talks about a murmur that is hard at the left sternal border. It's either you are dealing with pulmonic, this in-between area, or the tricuspid area. So you can easily predict what you are dealing with just by reading the question. Sternal border, left sternal border, left sternal border, left sternal border. So because you have so many areas around the left sternal border, there is another way they will qualify it. They must put it. It's not maybe. They must. If you need to narrow your diagnosis towards something, and that thing is either upper left sternal border or lower left sternal border. All right. So when you read the question and you see upper left sternal border in the question, you are dealing with pulmonic area. Even if you see any option that is related to these guys, this middle and the lower left sternal border, you don't go towards them, because the question specifically said the murmur was loudest around the upper left sternal border. All right, so if it's left upper sternal border, which is the P, so you will be seeing all these. You say it's pulmonic area, you will be seeing pulmonic stenosis, then the flow murmur. I will tell you about flow murmur. Flow murmur. So pulmonic stenosis. Yeah, Festus. Yes. Where is pulmonic regurgitation? No. Regurgitation from the outflow tract. Separate them from in your head. When you get into the exam, they are quite different. You separate them completely. So this is the pulmonic area. So here, just say pulmonic stenosis. There is another condition they are most likely going to put here, or they are most likely going to test here, which, if at all we have the opportunity of showing you in pediatric, we will unravel that, and that is ASD. Here too, we should do it. So you will see ASD here. This is where you will hear it very well. So you hear the murmur here. So when you check the question, just say murmur that is hard at the left upper sternal border. You just say, it's either I'm dealing with pulmonic stenosis, ASD. I will tell you about the flow murmur, how you separate it in the exam. So that's for the left upper sternal border. What about the left lower sternal border? So this is the tricuspid area. So something related to tricuspid valve, you will hear it here. So maybe tricuspid regurgitation. There's now another one you will hear here, is the FSD murmur. FSD murmur. All right. So I want you to pay attention to me very well. So for the pulmonic area, ASD. Tricuspid area, FSD. Can you see? So if at all the question is related to ASD, FSD, there's a way you will differentiate. I will show you. Is a very clear, easy way when we get there. So you just be like, okay, this is most likely the FSD. Oh, this is most likely the ASD. Just from the murmur, where they are picking the murmur. You just be this ASD, this VSD. So there is a way you characterize a particular, there is a characteristic murmur we call holosystolic murmur. For those that did step 1 with us, they will have gotten the understanding very well. What is holosystolic murmur? If the left ventricle should contract, the blood is expected to flow to the aorta. All right. If at all the blood flows through any other area apart from the normal area, the murmur you will have is holosystolic murmur. The same thing for the right ventricle. Oh yeah. Now let me bring it closer to you. Left ventricle contracts. The blood is now flowing from the left ventricle to the left atrium. All because the mitral valve is incompetent. The murmur that will be produced is what? Holosystolic murmur. Left ventricle contracts and the blood is flowing to the right ventricle through VSD. The murmur that will be produced, holosystolic murmur. Right ventricle contracts and the blood is flowing back into the right atrium. The murmur that will be produced, holosystolic murmur. Relax. You now get into exam. You read that beautiful question. You just mistakenly see holosystolic murmur. Don't read that question finish. Just write on the paper that will be given to you. It's either I'm dealing with tricuspid regurgitation, mitral regurgitation, or VSD. Holosystolic murmur. Maybe we should call them holosystolic murmur question, because they give you the vibe, the clincher that quickly tell you what you are dealing with. They will put it there, holosystolic murmur, because that murmur is during systole that is going to occur. So the next thing they now put, you've already seen holosystolic murmur. They will now say it is loudest at the tricuspid area. You just say it's either I'm dealing with tricuspid regurgitation or I'm dealing with VSD. Most time it's just going to be one of them they will put. If they are going to put the two of them, the question will separate them. And that's that. Holosystolic murmur at the mitral area, you are dealing with mitral regurgitation. All right. So that's just about this standard border. The last thing about the standard border I will mention is this area, the middle part of it like this, is not pulmonic area, is not tricuspid, it's just in between. So this area, they usually call it left sternal border. They don't qualify it, whether upper or lower. Most time in the exam, just left sternal border, left sternal border, left sternal border. If it's left sternal border, what will you pick there? That is where you are going to pick a murmur that's related to hypertrophic cardiomyopathy, ACM. That is the place you are going to pick the murmur that is related to the regurgitation fashion of the heart flow tract. So aortic regurgitation, pulmonic regurgitation, this area. All right. They tell you in the exam, the blood pressure is 170 all over 50. They now say they are picking maybe a systolic murmur at the mid or at the left sternal border. I just mentioned left sternal border. And they now give you this blood pressure. You just say, I already know what I'm dealing with. This blood pressure alone, the wide pulse pressure here, has already told you that you are dealing with aortic regurgitation. Just pick aortic regurgitation here. Can you see? Aortic regurgitation. All right, so that's just by the way. So we'll be looking more at those stuffs. And this is the aortic area. How will you know that this is all about aortic maybe stenosis? You know, I can't be talking about aortic regurgitation, aortic stenosis. They will tell you there is one clincher that will be in that long question. The murmur radiate to the carotid area. That's all. That's all. It will be there. The patient is having this syncope, this one, that one, blah, this. They keep saying all manner of stuff. They pick a murmur at this second intercostal space that radiate to the carotid. They just go through the ocean and go and pick aortic stenosis. That's the answer. His murmur will radiate to this. They will say the right sternal border that is radiating to the carotid area. Your answer is going to be aortic stenosis. What about the mitral? At the apex, so the murmur here, they are related to the mitral valve. Mitral valve prolapse, mitral valve regurgitation, mitral stenosis. They will all pick all of them here. So for the mitral regurgitation, you know definitely that one will be hollow systolic murmur. And that's that. All right. So when I get to flow murmur, I will tell you something about it. So, and that's all about the murmur here. So that's that about this area. So just rehearse it and get used to it in a way. So this is aortic stenosis, just for you to remind yourself the main point. So you see it in the aortic area, it radiates to the carotid. That's the main thing. They will put it in the what do you call it? They will put it in the question. So come down to the mitral and tricuspid regurgitation. You know that will definitely be hollow systolic murmur. So it will radiate to the axilla. So that's that about the mitral area. Mitral valve prolapse. Mitral valve prolapse. I've already told you how the murmur in them will look like. You remember, one arrow is going up, the other one will be coming down. So anything that increases the blood flow to the heart will reduce the murmur intensity. Anything that reduces the blood flow to the heart will increase the murmur intensity. That's what we give it out. So they now tell you that murmur, they are picking it at the mitral area. Most likely you are dealing with mitral valve prolapse. So there is a characteristic sound they usually hear there. You call it proclick. So proclick is actually due to the tensioning of the chordae as mitral valve reflex is prolapsing. So let me try to show you, if you don't mind, how that occurs, because it will help you to understand what is happening and you won't forget it. So these are the papillary muscle. Permit me to show you like this. So this is the mitral valve. So you now have chordae, tendinae, they are here. So in the course of prolapsing into the left atrium, this mitral valve, this strand, they become tensed. So if they prolapse here like this, they prolapse here like this. So what you will see is that this strand is now going to become very tensed. That tense is more like a string sound. So you will hear it proclick. So you just hear that clicking. So it's due to tensioning of the chordae as mitral valve leaflet prolapse. So that's this proclick for you. I put something here because it's another question you are expecting. You can easily predict the question around the mitral valve prolapse in step 2. Like you can sit down and predict it. Predict. This is the next question you are expecting in the exam under the mitral valve prolapse. Apart from the murmur, where you pick the sound, how you diagnose it. This is the last question you can talk about here. If at all they say this patient has mitral valve prolapse, now I want to do a dental procedure. I'll still talk to you about it later. So now I want to do a dental procedure. So do you want to give prophylactic antibiotic because you are afraid of infective endocarditis? No, you don't give it. Even though there is a prolapse, this is a normal valve that is prolapsing, does not make it, how do I call it? It does not make it a stranger. No, it's not a stranger here. So it's a normal valve. It's just prolapsing. So you don't need to go and be giving prophylactic antibiotic. These are the questions. Expect them. These are the ones that they can test in the exam. All right, so let's look at the FSD. You already know hollow systolic murmur. You'll be hearing it at the left sternal border, the lower part. So that's where you'll be hearing it. So that's at the tricuspid area. So I used to say something, the FSD, it can be big, it can be small. The cardiologist that means us here will know that, okay, if it's big, so you won't hear it that loud. If it's very small, it will be making a lot of noise. All right, so that's just by the way. Don't forget this. What about the aortic regurgitation? Only where are you going to pick it? You'll remember the what? The sternal border. Aortic regurgitation, pulmonic regurgitation. You'll pick them at the left sternal border. Never forget that. Left sternal border. So that's just by the way, in case they give you the question in the exam. If you are listening to the murmur, apart from the cardiologists and methods that are already used to them. So if you are listening to the murmur and you are like, what is this? What is this? What's going on here? I don't know what I'm hearing. What am I hearing? Just look at the BP. The blood pressure will give it out. Because you are going to see the wide pulse pressure is going to be very prominent. You just pick it. You don't even need to listen to it before you pick it. Wide pulse pressure that will be there. We give it that. Unless they want to do ICA. They want to do, what do we call it? So if they do not just want the answer to be gotten, then they won't put the blood pressure there. Because they know from the blood pressure alone, you are not going to listen to any murmur. You already know that you seeing 170 divided by 50. You already know this is aortic regurgitation until proven otherwise. Or the question, they start mentioning some signs that I'm going to mention very soon. All right, this mitral stenosis. Again, this mitral stenosis, definitely we will be hearing this at the mitral area. All right, and it's going to radiate towards the axilla too. So never forget that. All right, so you hear it at the apex. So that's that. The kind of sound you are going to hear here after the S2 is the snap. You call it opening snap. So they will mention it, opening snap. And if I thought they do not differentiate it, I will differentiate it very soon. All right, so that's just by the way. Mitral stenosis is one of the sequelae that can occur in a patient that have rheumatic fever. So rheumatic fever, and this is the most common valvular manifestation you will see here. Apart from that, aortic. Apart from that, the tricuspid. All right, so that's for the rheumatic fever. So please never forget this. Patent ductus arteriosus. In the exam, the murmur you hear here is continuous murmur. Continuous murmur, continuous murmur, continuous murmur, continuous murmur. You just read the question, you just say continuous murmur. Two diagnoses must come to your mind. Number one, patent ductus arteriosus. Number two, venous hum. How will I now know the difference between the two? Because they know that when you hear, you read, you see in the question continuous machine-like murmur, you will be shouting PDA, 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 because everybody knows that. Even an unborn child knows that the continuous murmur, machine-like murmur, is actually PDA. But the question is not about PDA. It's about another thing entirely. That thing that is all about is venous hum. It's also a continuous murmur, and it radiates towards the neck. So, but there is something about this. The murmur can actually reduce. You may not hear it as such again or change with neck flexion. So in the exam, when you read the question, just quickly trace it, because in the exam, just see continuous murmur. You are like two differentials, PDA or venous hum. Just trace the. You don't read it, just trace. You are looking for neck flexion, neck maneuver that is changing the murmur. Now saying the murmur intensity reduces when the patient flexes the neck. It's not PDA. Most likely you are dealing with venous hum. All right, and that's how you differentiate them. So please go into your question banks and try to rehearse all these stuffs. You should be fine. Now, this is just for you to differentiate the mitral valve prolapse, mitral stenosis. All right, so one of them is pro. Pro is like before. Pre, something like that. So our focus is something like this S2. All right, so pro click. So before S2. So this is where you are going to hear it in case they give it in the exam. Why the steno snap? It's going definitely to be after S2 now. Another important point is you already know that this mitral valve prolapse, anytime the preload is reducing, murmur will increase. If the afterload is also reducing, murmur will increase. So if you look at the afterload increasing, preload increasing, murmur is reducing. Can you see the way they are alternating themselves? So that's for mitral valve prolapse. So another thing, the condition that does like that is ACM. Don't forget ACM. ACM. So for the mitral stenosis, so you will see the arrow we go in the same direction. Preload increases, the murmur intensity will increase. Preload reduces, the murmur intensity will reduce. That's for the steno snap, and that's after S2. All right, so that's just by the way. Focus on the S2 in case they give you this in the exam and they now put it, they are hearing a murmur here before S2. Just know that's most likely to be pro click. S2 is your reference point. You can use that if you wish. So if this is actually, if this is before S2, then this is definitely the systole. After the S2 sound, you have the diastole. All right, so this is systole, this is diastole. So the proclick occurs in systole, proclick, while the steno snap occur in diastole. This is the flow murmur again. Flow murmur is positional dependent. They will ask you a question on this in the exam. They say the patient, they are hearing a murmur. There is a child, usually common in children anyway and young adults, very common. You know, see the mother, I'm trying to look for a way to put it. There is a young child that is having a particular murmur or something like that. So when the child is maybe standing, the murmur is there. When the child is lying down, the murmur disappears. Or once you read the question, you are seeing positional influence on the murmur. Lying down, disappear. Waking up, this one is reappearing. Once you start seeing something like, just be like, you are most likely dealing with flow murmur. It's a benign murmur. It's just a flow murmur. No tree, nothing. So flow murmur. Just a flow murmur. Just check all the options and pick flow murmur. All you need in the exam is position. You just say, child. You are also having murmur. You are a child. A child is yes, a child. How old is? Just check. Any positional influence on the murmur, they say yes, is there on the second line, third line, fourth line of the question. The answer is flow murmur. Just that's the flow murmur until proven otherwise. And that's that about that area. What about these gallops? Gallops. These are the additional hard sound. The S3 gallops, S4 gallop. What you want to take into the exam is basically when you read your question, you see S3. Don't let stuff cloud your judgment. The exam is not too much stuff. That's why people that don't really read much, like the way they pass. Whereas people that read a lot, they don't pass that much because their thinking is towards so many things, which is true. So many things could cause it. Sometimes when we take webinar like this, and I'm looking at a question, people will be like, this is just B now. And I will be like, B? Are you sure it's B? I might be like, maybe it's C actually. We check the answer and it's B. It doesn't mean C is, I was just overthinking about it. So you don't need to overthink about it. The more you start saying you want to know a lot towards the exam, yes, it will help you because you can say a lot of jargons, but in the exam, it does not help. Because simple question, you'll be overthinking about it. Trust me. You will overthink. Is this? They brought this question about this. It's a lie. The questions are very simple. Because whatsoever you think you know now, US is going to retrain you. Even if you are a consultant cardiologist, they will still retrain you on it. Like everything you've known, you are most likely going to drop them until you start thinking like a United States doctor. That's why just take it easy. S3 gallop is just a sign of fluid overload. So most likely the question is heart failure. So you can basically just say that you are reading a question, you just trace. You have 40 seconds left for that question. You just say heart physical examination S3. Immediately you see that S3, just say, I hope this patient is not having heart failure. You now check through the options. You see, apart from heart failure, there is no any other thing there that could have justified that. Is just pick that heart failure and go without even reading the question. Just by saying S3. So that's that. This is the commonest stuff they link to the S3 gallop in the exam. All right, so please watch out for this. Another thing is this mitral valve disease, which I'm not expecting them to bring out, then it's normal in young patients and in those with high output state, like pregnancy, those that are pregnant. So that's ST. Just remember heart failure until proven otherwise. You don't need to be correct, but you remember one key point. Now, some people will want to remember everything they've put here. You are only deceiving yourself. You will forget them. S3, heart failure. S4, you read the question. S4, 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 S4. All right. Hypertension and any other thing that could have followed hypertension, diastolic dysfunction, usually pathology, but can be normal in younger patients and in athletes. So hypertension, in fact, these three are very important because they flip questions around the three of them: hypertension, aortic stenosis, DAS. So S4 is I had S4, S4. So hard here is just HAD anyway, not hard. So hypertension, aortic stenosis, diastolic heart failure. Now, this is S3. This is S4 in the exam. S3, the third letter in the alphabet is letter C. The fourth letter in the alphabet is letter D. S3, you have a systolic dysfunction. While letter D, S4, you hear it diastolic dysfunction. All right, so when they give it and the question is about systolic, diastolic, just know systolic, S4 diastolic. All right, so the summary you need is another key fact. It shows that all the jargons we've said: more blood, increased blood flow, increased preload, will increase more in everything except mitral valve prolapse and HOC. You already remember that. I put something here, Ring's legs. Possibly that may help you if I thought you revise that. So right-sided murmur will increase with inspiration because more blood will flow towards the right heart. However, there will be a reduction in blood flow towards the left during inspiration. So therefore, the left-sided murmur will reduce during inspiration. So why they will increase during expiration. So rings means right-sided murmur will increase during inspiration, while left-sided murmur will increase during expiration. Rings legs. Edema. That's what you were shouting, edema, edema, edema the other time. Yes, we were shouting edema. Pulmonary edema, you see it in left heart failure. Fluid back up into the lung. This is not a new fact to anybody here. Peripheral edema, I was shouting the other time. Do not forget almighty hepatojugular reflux. Almighty hepatojugular, for you to know, is it from the heart or is from the liver? So they will put it there. If you are seeing that reflux is there, you are seeing with that pressure on the liver, you are seeing the jugular venous distension, then whatsoever you think is responsible for the edema is most likely to be related to the heart. Why, if they say they do it, it's not there, you are most likely dealing with liver cirrhosis. So don't forget this in case that's given in the exam. What about the hand? Finger clubbing, congenital cyanotic heart disease, endocarditis, infective endocarditis, splinter, hemorrhage, and the other stuff that we see, Osler Nogin way. What about the peripheral pulses? Peripheral pulses. So it can be increased in aortic regurgitation. In fact, the way they will put it is bounding. Pulse, bounding, bounding, bounding. How are you bounding like this? So when you see it, so it'd be like, hope I'm not dealing with peripheral. Hope I'm not dealing with aortic regurgitation. Dr. Adibowale, you are smiling. Sorry, I just need to distract us a bit. Don't mind me. Okay, that's fine. So that's for the aortic regurgitation, peripheral pulses, the coarctation, the patent ductal arteriosus. So PDA, the murmur you see here is what? Is the continuous. Who remembers the second condition I say you are also going to see the continuous murmur?
Venous home.
Venous home. So how will you differentiate the two of them in the exam?
Neck maneuver.
Neck maneuver. Exactly. So once you see the murmur is disappearing or reducing with neck flexion, this venous hum. All right. So that's just by the way. This is decreased pulses. Maybe you are dealing with peripheral arterial disease. The kind of questions they ask on these, how they ask them, I will try to show you if I thought we get there. Water hammer pulse or collapsing pulse. You also see it in aortic regurgitation or incompetence. So this is the one they are most likely going to link to. You see all these thyrotoxicosis, severe anemia, PDA, they are most likely not going to link them to it. But this collapsing pulse, aortic regurgitation, increased pulse or bounding pulse, aortic regurgitation, expect question on them. So you can come here and just look at things and go. Instead of you sitting down here and be shouting, cardiology is difficult, because you want to be a cardiologist within 3 days that you want to use to read the cardiology. So that does not make sense. So if you do it like that, you are most likely to be misinterpreting question because you are trying to be perfect. Pulsus paradoxus. Pulsus paradoxus. Normally, if you look at inspiration, we've been shouting something for some time now, that with inspiration there will be increased blood flow to the right part of the heart, while there will be reduced blood flow to the left part of the heart. So what it means is that during inspiration you expect the systolic blood pressure or the cardiac output to drop. So if the cardiac output is dropping, systolic blood pressure is dependent on the cardiac output. Therefore, the systolic blood pressure will drop during inspiration. So as you inspire now, as I inspire, my systolic blood pressure drop. But you don't expect it to drop beyond 10. You don't expect it to drop beyond 10. So if you now check the question, you now say during inspiration, the systolic blood pressure is, maybe expiration, the systolic blood pressure is 120. They now say during inspiration, the systolic blood pressure is 108. Once you see this, just know you are dealing with pulsus paradoxus, because the systolic blood pressure has dropped by more than 10 millimeter of mercury. That's all. What's the diagnosis? COAT, C-O-A-T. This is just what you are looking for. Means the options. Am I dealing with cardiac tamponade? Am I dealing with obstructive lung disease? Am I dealing with asthma? Am I dealing with tension pneumothorax? If it's going to be tension pneumothorax, you will see either they say there is reduction in heart, breast, and this one, that. You shall put something related to it. Then if it's asthma, they will have put a clincher there for the asthma. If it's obstructive lung disease, there will be a clincher there. If it's cardiac tamponade, there will be a clincher towards them. If I say we should differentiate them, now everybody here will differentiate these four. Whether you know it's correct or not, but you can say something about them that patient is likely to present with. Maybe the patient had an accident or something, or has something. Just be okay. Maybe I'm doing cardiac tamponade, obstructive lung disease. Maybe the patient is having this, that. Yes, asthma means the patient is having this. So you can easily differentiate them. So, but you will just see the blood pressure. Another way they bring this one out is through graph. They will just put the graph like this. You just see the wave. They will give you a wave of how the blood pressure is changing. So they now come and bring it down. They take it up again. They bring it down. So you can easily say that this is when you are dealing with expiration. This is when you are dealing with inspiration. So you now look at the peak here. The peak here is 120. The peak here is like 108 or 105. You can see that this difference between the two peaks is actually more than 10. You just say you are dealing with pulsus paradoxus. So your diagnosis will be any of these four guys. What about the pulsus alternans? So just alternating weak and strong pulses. You can see this in cardiomyopathy. Pulsus perfus etados. You call that weak and delayed pulse. This is how they will put it. You just say the pulse is weak. The pulse, or they mention pulsus perfus etados. They are not speaking in tongues, but at least you have an idea. Aortic stenosis. So, and you know where you will pick the murmur, aortic area, and it will radiate to the what? To the neck, or the carotid region. All right, Jackie, this one they hardly test them, but just let us note it. Hypertrophy obstructive cardiomyopathy, pulsus bispherians. So, bifid pulse or twice beating pulse, aortic regurg, and the likes. So, HOCM. You can just know. But these are the common ones. Pulsus perfus etados, pulsus paradoxus, collapsing pulse, bounding pulse, and the likes. All right, so I'm going to unravel a little mystery for us about atramysoma. I know you know it, but let me still try to summarize what you've read or you know before. So just for us to have an idea of what we are expecting them to bring out in the exam, and anyhow they try to complicate it, you can still reason one or two things out. All right, so this is atramysoma. This is atramysoma. I want to draw the art. So this is permit me to just represent it like this, that this is the right, no, this is the left atrium, this is the right. So this is the right, this is the left. All right, so the thing about the atramysoma is that it's a benign tumor of the heart. So usually where you see it is in the left atrium. Festus, is that important thing? Shit. It is highly important. Highly important. Where you see it is in the left atrium. Commonly. Now, does that mean you cannot see it in the right atrium? It's a lie. You can also see it in the right atrium. All right, you can also see it in the right atrium. So it can also be here. Festus, what are we saying? This is becoming confusing. Relax. Step 1 actually try to, well, we just finished our rapid review pro for step 1. So I try to differentiate them in a more elaborate way, but I'm not going to waste your time. So I will use this to predict out the likely questions they can bring out here. So where you are expecting it to be is actually the left atrium. Like 90% of the time, that's where they are. But you can also see it in the right atrium. All right. So that's just by the way. Please note that, because in the exam you may just go there and say they claim that there is one there is a particular mass they are seeing in the right atrium. You now say, I've never seen that. It can be myosoma. It can be atramysoma. You know, it can be. So please watch out for that in a way. All right. The way they describe it is a ball valve. A ball valve. So please never forget this. They can put it in question, they may not put it there. So the thing is that if it's a ball, it can easily obstruct the mitral area. So it can easily obstruct the mitral area. That's another point you want to note. So if it's obstructing the mitral area, it shows that blood cannot easily be emptied from the mitral, the left atrium into the left ventricle. As a result, the cardiac output is definitely going to drop because blood is not even coming to the left ventricle. So if that is the case, the patient can present with symptoms and signs that are related to obstruction or reduced cardiac output. They can also put a sound in the question. That sound, you call it tumor plop. They are not speaking in tongue. It is the way they put it here is most likely the way it will be in the question. Tumor plop, tumor plop, tumor plop, tumor plop, tumor plop, tumor plop sound. Just say tumor plop, tumor plop. You read the question, tumor plop. I hope this is not this atramysoma you are dealing with. All right, so please never forget that. They can also put that there. Then the patient can have all manner of constitutional symptoms. So all those constitutional symptoms, they can test you on it. What do you think is likely responsible for them? Is interleukin-6 production. So please watch out for them testing on interleukin-6. They can put early diastolic tumor plop there. They can ask you, usually step 1, they ask about the histology, which can occur in step 3. So step 1 is histology. They can ask you, and the histology is just this description here: gelatinous material, myosoma cells amassing glycosaminoglycan. It's more like you're speaking in tongue. It's gelatinous material, myosoma cells amassing glycosaminoglycan. Someone will say, amen, amen, amen. So it's just more like you're just rhyming something. So, but just rehearse it. This is step one concept that USMLE is going to test. They will just give a question and just say that what will you see on histology? All right, that's just by the way. For step two now, what's the best next step? The best next step will be echo. I want to do echo. With that echo, you say the patient came, is having dizziness, having syncopal attack and the likes. You now say that when I was examining, I was hearing a tumor plop sound. And that's what do you want to do? I want to see what is in that place. So echo. So now you've seen that the patient has a mass, and you're thinking towards this atrial myxoma. What do you want to do? You say surgical resection, and that's that. So metastatic commonly affect the right side of the heart. So Festus, you were shouting the other time that it can occur on the right. It can occur on the right. How will I know that it can occur on the right? So there is a tumor, that a cancer that can affect the right side, that can actually give rise to the one on the right side, and they will test it in the exam. You call it melanoma. So anytime you see this atrial myxoma and they say, what do you want to check for? Most likely you just need to go and rule out melanoma in that patient. So, and that's that. You can see echo, you can see tumor research. They put it in key facts because it has been tested before, and you are expecting question on it. So that's that. You can predict the question, the facts over time with your first aid. And that's that. All right, before you start developing headache, let me give us a 15 minutes break. Abi, do you think you don't need break? Do we need break or we don't need break?
I need break.
I'm seeing thumb up, thumb down. Wait, let me just
thank you for the break, sir.
Let me give us.
Need the break.
Yeah, let me give us 15 minutes break. So, according to my screen here, we'll continue by 3:47. So that's just by the way. Thank you. All right. So this is actually arrhythmias. I know some people, when you hear the word arrhythmias, you'll be like, cardiology arrhythmia, where will I start from? Come on, give yourself headacheless reasoning. You do not need to know the whole arrhythmia that you have ever seen in tests before. They are very specific. Just basic arrhythmia basic knowledge on arrhythmias that can save life. So you can even predict what they will test. In fact, when I was flipping through this page, I was like, oh, you can test this, you can test this. You can say them. You've got to be pointing your fingers at them because they are very specific in what they test in the exam. And what they will test Dr. A might not be the same with what they will test Dr. B. And everything will still revolve around the same thing. And for all you care, even though we are going through 88 pages, the whole question they will give you in the cardiology may not even be up to 12 questions. So why do you not want to kill yourself? So, and those questions, even if you do not read for USMLE, step 2, you may still be able to guess some of them right. So if I told you are now reading, please just give yourself peace of mind. Pick 1 or 2 points and move on. But because of the nature of the question banks that many people are using to read, they tend to overthink about the exam. Bradyarrhythmia and conduction abnormality. The first question you should expect in the exam is about sinus bradycardia. And you already know that when you talk about the sinus reading, you have the P wave preceding the QRS complex. So what you will see is that they will just give you the ECG, and you just look at it. All you will see is that you can see P wave and you can see QRS complex. And when you calculate the heart rate from the QRS complex, the big boxes between them, 300 divided by whatsoever you count, you are seeing something less than 60. You just be like, this is looking more like sinus bradycardia. You will see it's going to be regular. Like you will see it is regular. All right, so that's just by the way. So what are the causes of it? Maybe we are dealing with sinus node dysfunction. It's not discharging the way it should. See the way I'm talking like this. Oh, they can give you this. If it's sinus node dysfunction, just be like, they can give you this. It's still saying the same statement, but it's very slow. So sinus node dysfunction. So AV node, nodal blocking drug. If I say we should mention them, there is no one that will not mention them here. So beta blocker, not dihydropyridine calcium channel blocker. So anytime you read a question, you now say sinus bradycardia, you want to quickly check. Hope it's not the drug. If they say the patient is actually hypertensive patient that is on beta blocker, that is now having something like this sinus bradycardia, maybe the patient is taking a lot of it, that they might just need to review the medication. That's all, to review the dose. All right. So if this is now where they will ask the question again. The next set of questions is about the treatment. So they know that you've already made the diagnosis of, oh, this sinus bradycardia, this sinus bradycardia. Now be like, what is the next best step? Now, you don't just choose anything blindly. If the patient is asymptomatic, just check, is this patient having any symptoms? So if the patient is asymptomatic, you don't do anything. You just say, just reassure. Do you get me? You can reassure. You don't give anything. You can review the medication and reassure. So if at all the reassurance is not there, you know that it's due to medication, just pick review medication. That's the only thing. You don't do anything. You don't give them any treatment. But if the patient is symptomatic, your answer for the next best step is going to be atropine. They are not two. It's atropine. It's the one they will test. It's the one they've been testing. It's still the one they will test. You see this transcutaneous, this second line transcutaneous pacing or dopamine epinephrine, if they don't test it, no, they don't ask it in the exam. This is the one. Atropine is what they test. More than 99.9% of this question that they might have given is all about and is related to the treatment. It's just atropine. So you are revising, you come down to this place and you are like, what do I want to remember as I'm going into the exam? Atropine is atropine. You see it, the patient is symptomatic, just pick atropine and get out. So, but if you put the three of them at the back of your mind, when you get into the exam, you will be confused because you don't know which one do I pick, which one don't I pick, which one do I pick. That's where confusion starts from, because you overread. So atropine is the most likely one. That's why the arrow is on it. So please watch out for this one very well. So let us assume the atropine is not in the option. The second line, that's when you be thinking towards transcutaneous pacing or dopamine or epinephrine infusion, but it's probability that this one will be tested very low. The reason is that they still want you to pick the common things that occur commonly. So what about the definitive treatment? If at all this is not related to medication, this is not related to anything that you can review, the patient is still having sinus bradycardia, the definitive treatment is going to be permanent pacemaker implantation. So you want to note this one too, permanent pacemaker implantation. And that's all about the sinus bradycardia. What about the AV blocks? So everybody here, you know about the AV blocks. So we have the first degree AV block, we have the second degree, we have the third degree. So for the first degree, all you see is that the PR interval is quite prolonged. So it's going to be greater than 200 milliseconds. So it shows that it's more than 3 to 5 small boxes. So that's just what you see. So the PR interval, can you see it? And it's going to be constant like that. Prolong. So when you see this in the exam, what are the causes? It can occur in normal individual. So it may be due to increase in Fager tone. It may be due to a patient that is placed on beta blocker, just like the sinus bradycardia too. So beta blocker or calcium channel blocker and the likes. All right, if the patient is asymptomatic, you don't give anything, you don't do anything. If the patient is symptomatic, you can also give atropine. It's just as easy as that. So treatment is not necessary if the patient is asymptomatic. So most time patient will be asymptomatic. So please just watch out for this. Just pick no treatment is required. No treatment is required. That's what, if I thought they will test this, that's what they will give. So what about the second degree AV block? This second degree AV block, they are divided into two. We have the type Mobis type 1, Mobis type 2. for the Mobis type 1, that's when you will see this progressive increase in PR and eventual drop. So you just see progressive lengthening of the PR interval. Can you see it's increasing, 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 increasing? So this you can see, just look at it. Then it's now drop. You can't see any wave here. So you be like, this is Mobis type 1. You see it progressively increasing, then it drops. All right. So that's for Mobis type 1. So that's for Mobis type 1. You call it Wenke back. So please never forget that. The causes, roughly the same thing. This may be due to right coronary ischemia for those that are used to, or infarction, or those that are used to our step 1. You know, the right coronary artery supplies the node, SA node, AV node. So if I told you there is something wrong with right coronary artery, definitely the AV node is going to be dysfunctional. So you can have this second degree AV block manifesting in them. All right. So if the patient is asymptomatic too, do I need to treat? No, you don't need to treat. If the patient is symptomatic, then you can give the patient treatment like atropine. So I just put something here, first degree AV block and type 1 Mobis, just reassure, unless the patient is symptomatic. Just reassure, 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 reassure. So your assignment will just be that if I thought they give me ECG, okay, this one is constant, this one is progressively increasing or lengthening. So that's for Mobis type 1. For the one that is constant, for the one that is constant, that is first degree. All right, so that's just by the way. What about the Mobis type 2 and the third degree? The Mobis type 2, the way you will see it is normal PR. PR is normal, PR is normal, PR is normal, is now dropping. PR is normal, PR is normal, PR is normal, and it's now dropping. All right, so now before I go further from here, I used to make an analogy in step 1. And the analogy is that in my family, let us assume that anytime I go to work, I always come back late. That's my nature. We finish at work at 5. I will talk to everybody, talk to this. You know, some families are like that. When they go to church, you get home, you ask, where is your dad? Is there, you know, daddy now? He's always going to do church after church, because he's going to greet all the family. So they know that if the church closes by 2 o'clock, daddy will be coming home by 5 p.m. So that is Mobis type 1. If I thought they are not seeing daddy by 3 p.m., they know the family member will not be disturbed. They are not seeing daddy by 4. They won't be, because they know daddy is always coming back late. That's his nature. All right. For the second degree, just suddenly, daddy that has been, anytime daddy finishes from church or this man finishes at work, he's always coming back home. But suddenly, the man just from 5 o'clock, he gets home by 5:20. From 5:20 to 5:40, 5:40 to 5 at 6 o'clock, 6 o'clock to 7 o'clock, 7 o'clock to 8 o'clock, 8 o'clock to 9 o'clock. After a while, now call the wife and be like, I won't be able to come home today. The wife will not be bothered, because the wife is already getting used to it. It just be like, okay, no problem. Okay, you are also late today. No problem. So that's for Mobis type 1. So you don't really need treatment. The wife will not be jumping and be shouting, I don't see my husband. So that's the drop. So look at the second degree AV block type 2. The man comes home every 5 o'clock, 5 o'clock, 5 o'clock, 5 o'clock. Suddenly, the man does not come home. If you were to be the wife, won't you jump to police station? Then he needs treatment. Because suddenly, the PR interval that has been normal, you now start seeing a drop. Then you need to treat. So normal PR and sudden drop in the beat. So the treatment here, even if the patient is asymptomatic, you treat it. And that is the treatment pacemaker. So when you read the question, you look at the ECG, just quickly check the PR interval. Just check it. And normal, 3 to 5, 3 to 5, 3 to 5. Then sudden drop. Now what you treatment. You now see reassure. B, atropine. C, pacemaker. This one that has been normal, and suddenly, something is going on. Pacemaker. So this is the answer, even if the patient is asymptomatic. All right. So what about the third degree? What about the third degree? The third degree, what you have here is more or less like desynchronization between the atrial contraction and ventricular contraction. Atria doing their own, ventricles doing their own. Something is wrong. So you see the ventricle will be contracting their own, atria also will be contracting on their own. Can you see? And if they are contracting on their own, this one doing its own, this one, at some point you may see them overlapping. They will contract at the same time. So that's what you are seeing P wave on the QR complex here. So when you see regularities in RR interval, RR interval is going to be regular. And when you check, you will see all manner of abnormal atrial contraction that is just being recorded here. So you can see this is one, this one, this is one, this is one. You can see them, they are just there. So what we give it out is you will just see the RR interval will be regular. However, for this second degree, it's not regular because you have a drop here. So that will draw you closer to the third degree. Apart from the other clincher they may put there. All right, so that's just by the way. So what's the treatment for the third degree pacemaker to pacemaker? It's just pacemaker. So you don't need to overread there, just a pacemaker. Pacemaker is pacemaker. So once, whether symptomatic or is in pacemaker. So that's that. The last question you should expect here is, where do you think the problem lies? The problem is actually in the Purkinje system, East Purkinje system, bundle of East and the Purkinje. That's where the problem lies. And these are just the questions you are expecting them to test in the exam: the pacemaker, the diagnosis, and where the problem lies. This is the sick sinus syndrome, tachycardia, bradycardia syndrome. Sick sinus. How will I know this is sick sinus? Most likely the patient is going to be an older patient. So you just check the question. You are most likely to see maybe 70 something years old that is having this kind of ECG. You'll be like, this sick sinus. So most of the time it's as a result of what do we call it? More or less like degenerative changes occurring in the SA node too. So just watch out. So for that sick sinus syndrome, so please watch out. The treatment is pacemaker. Just look at the ECG and check the age. So you are most likely going to see that the patient is going to be older patient. So like this, you can see 71-year-old man, and they now give you the ECG. Let me try to bring out that ECG, sick sinus syndrome ECG one. So can you see? This is one. Look at this place. See where the second KRS. See it here. Can you see the way it's just, you already, can you see the long distance? Sinus SA node is not really bringing out or throwing out the impulse. So you now check the age of the patient, looking more like sick sinus syndrome. So it's just a degenerative changes in the SA node, AV node, everything together. All right, so that's just by the way. Let's watch out in case that's tested in the exam, because with age, patients, we have degenerative changes in all our organs, the tissue, and the likes. All right, so that's that. Basically, that's just what I just need to show you under the bradycardia. If you look at it, not difficult, apart from the AV blocks that you just need to note, rehearse. Then if it's Mobitz type 2 or type 3, pacemaker straight. If it's type 1 or first degree or Mobitz type 1, you don't just need to reassure unless the patient is symptomatic. So this is tachycardia. All right. So how will I know what I'm dealing with? So sinus tachycardia, basically, you can see you just check the question or check the ECG that will be given. You see the ventricular rate will be more than 100, which is more than normal. All right, then you may see one or two physiologic process in the patient. Either the patient is having fever, having pain, or is exercising. So you just see it, they just say, oh, this is just sinus tachycardia. So it can also be secondary to hyperthyroidism, volume contraction, infection, pulmonary embolism. Anyone it is, the question will bring it out. You shouldn't be your headache. So if it's hyperthyroidism, you see the heart rate will be more than 100, and you see them talk about maybe the tremor. They are talking about what do you call it? Lead lag, this one, that one, esophthalmos, anyone that they shall want to link to that pattern, shall put it there and just see the technique. I'll say, what do you think is causing? What do you think is? Now give you the ECG. Now see what's diagnosed. Just say the sinus tachycardia. So how do you want to treat it? Just address whatsoever you can see in that question that is causing it. Just address it. That's all. If it's step 1, they may be asking how that condition is causing it. For example, the hyperthyroidism, they may be testing the beta 1 receptor. So whereas in step 2, they are not going to test that. So you just say, what do you think is responsible for the ECG finding? The answer will be hyperthyroidism. All right. Atrial flutter. There is no one here that will say, I am seeing someone draw this ECG for me and I do not know it's atrial flutter. It's a lie. The sawtooth appearance will not become smooth tooth appearance in the exam. It's always going to be sawed. You see, so. Just say atrial flutter. For all you care, that is the question. For all you care, you've read everything about atrial flutter. Just get there. It just give you the ECG diagnosis. Just see A, atrial fibrillation. B, atrial flutter. Just see the sawtooth. You just pick atrial flutter. Just say, wow. So this all they will ask me. Yeah, that's all. So I'm not saying definitely that's all, but it can be that simple. So very easy stuff. All right. So that sawtooth appearance of the P wave will help you out to narrow it. They've tested it before, like very well. That's why you see arrow on it. So then, where is the problem coming from? This is the second question you are looking for in the exam. Where is the problem coming from? It's actually as a result of reentrance circuits, most commonly passing between the inferior vena cava and tricuspid annulus. You call that carphotricuspid isthmus. So if you can shall remember carphotricuspid isthmus with respect to atrial flutter, that's what they will ask. So where are you seeing the reentrance circuit at the carphotricuspid isthmus? This is the second question most of the time they test in the exam for atrial flutter. So carphotricuspid, carpho. So you can come here and just say, look at the ECG, remind yourself carphotricuspid, because in the exam that's how they will write it. They will just write it like that. So you don't need to overthink it in the exam. All right. So how about the treatment? So the treatment may actually look like the way you treat the atrial fibrillation, basically. So don't give yourself a headache on that. What about the atrioventricular nodal reentry tachycardia? You see, atrioventricular nodal or atrioventricular, this reentry tachycardia, you can divide them into 2 basic categories. So this is it. This is the heart. This is the SA node. This is the AV node. Permit me to just represent them like this. This is the atria. These are the atria, and these are the ventricles. So I can have a reentry from the atria into the ventricle here at this level. I can have a reentry here at this level. And I can also have a re-entry here when that entry is not supposed to occur is occurring. So this one that is occurring at the level of the node, I will call it atrioventricular nodal re-entry tachycardia. Why this one? I will only call it atrioventricular re-entry tachycardia. One of them has nodal in its name. The other one does not have nodal in its name. What could have caused this one that does not have nodal? Maybe I just have one abnormal bundle, abnormal fiber, just shunting the impulse or wave of depolarization from the atria to the ventricle. A very good example, Wolff-Parkinson-White syndrome. Why this one that is occurring at the nodal? So this one we call atrioventricular nodal re-entry tachycardia. A very good example is this supraventricular tachycardia. Supraventricular tachycardia. Can you see? Now, relax. You cannot go into that exam and claim that after eating ogbono soup, they won't ask me question on atrioventricular nodal reentry tachycardia. You can bet it that one of the ECG they are going to give is this supraventricular tachycardia. One of the ECG you are expecting in that exam is this one. So if you already have it at the back of your mind that they are most likely going to ask you a question here, just sit down on it. Pick all the points so that when you get into your exam, how the question comes, just be there. This is the answer. This is the answer. So this ECG is the one that will not change. That's one good thing about first aid. It's not going to change. So you just see it. You just get into your exam, just see the ECG like this. Can you see the way they are? Now let me take you through a journey. Come online. So let's type something like supraventricular tachycardia. So let's put something like ECG there. So now look, something like this. Can you see? Can you see? Can you see all of them? Can you see? Can you see? Can you see the way they all are? So they will just give you the ECG, just say something like this. So you can just say this is looking more like supraventricular tachycardia. This is looking more like supraventricular. Just the way. So if you can put that picture at the back of your mind, that will be good. If you think the back of your mind is full, shall note it by all means. Can you see this one too? Can you see something like this? Supraventricular. USMLE love this one like mad. Like you can even say, if someone is saying they gave me ECG, you can ask, hope it's not supraventricular tachycardia. You'll be like, how will I know? How will I know? All right. So that's just by the way from the ECG they give. What you will see there is this retrograde P wave. They won't ask you about retrograde or no retrograde. No one will ask you for the attribute of the wave. So if you don't mind, you can ignore. No one will ask, will you see P wave, retrograde P wave, or will you see what will happen to? No one will ask that. I can bet that with you. They will just give you the ECG and you make the diagnosis from it. Just the way it looks, that's how it's always going to look. So it doesn't change. It's not that maybe the shape will change somehow. All right. So that's just by the way. How will the patient present, or how will the question come? They can give you ECG with no P wave before QRS complex. So, or no, you may not really be able to say this is the identifiable P wave for me that you can see. So, and they now say the patient is having chest pain. Relax. Let me portray that again. They may turn it to words. ECG is done. There was no identifiable P wave there. Immediately you see no identifiable P wave, you are like, atrial fibrillation, atrial fibrillation, yeah, relax, Mr. Atrial fibrillation. Relax, check that question again. Most of the time, if you are going to go for supraventricular tachycardia, you see the patient will come together with chest pain most time. Most time with atrial fibrillation, they don't have chest pain. They can also have chest pain, but most time they don't have it. They don't have chest pain. But this one, we definitely have chest pain, or most time have chest pain. You see chest pain there. So when you read the question, you see chest pain, and you now see this kind of wave, or they talk about the ECG, no identifiable P wave, something like that, and you are just like, wow, this is, just check the question. Yes, chest pain, yeah. Most likely, I'm dealing with supraventricular tachycardia until proven otherwise. So that otherwise, you can just check the question if at all you see something that can link it up with atrial fibrillation, which I will show you when we get there. So now that's the first set of questions. And for all you care, this might just be all they will ask you here. Just diagnosis. The next set of questions is about the treatment. Now, that treatment, what you will do, you will now go back to that question and check, is this patient stable? Is the patient unstable? How will I know the patient is stable or not stable? Check the pulse, check the BP, check the presentation. you can basically say whether the patient is stable or not. So if the patient is unstable, the diagnosis is the treatment is cardioversion. So because in the option, they will write cardioversion option A, option B, Fager maneuver, option C, adenosine, option D, we shall put something there. All the treatment you've ever mastered will be amidst the option. So the thing will now be, which one do I choose? Just check, is this patient stable? If the patient is not stable, you don't have time to be doing, extend your neck, let me rub this. No, you don't have that time. You don't have that time. Because from instability, the patient may die. So it may worsen. So just note that cardioversion for if I thought the patient, this is your answer. So if you can check the question, the patient, you just do the ECG, but the patient is actually stable. So the next thing you want to say, what's the best next step? You now check the options. The best next step is all about treatment. Your answer will be Fager maneuver until proven otherwise. Fager maneuver until proven otherwise. All right, so please never forget this. Now, why did I say until proven otherwise? Because one of the Fager maneuvers is carotid sinus massage. You get to United States, you've read a lot. You see the ECG, you are shouting, supraventricular tachycardia, supraventricular tachycardia. Mr. Sheets, how are you? You say, I'm fine. You say, sorry, we just check your ECG. You are having something that look like this. So if you don't mind, okay. You are still blowing grammar. Before you do that Fager maneuver, you must be sure that the patient does not have any history of MI, TIA, or stroke. Why? That carotid sinus massage you want to do, the stroke, TIA the patient had before, might be coming from atherosclerotic plaque from the carotid vessel. So in the course of doing the massage, the patient can develop another stroke. In the course of saving, you end up giving the patient stroke. All because something was omitted. And that is this history. So in the question, if they put the patient, there is a previous history of TIA or stroke or MI, don't do Fager maneuver there. Like this carotid sinus massage, you don't do it. Because in the course of massaging it, you will dislodge some other atherosclerotic plaque. They will now go and give the patient another TIA or give the patient another stroke. That is why this point is very important. The first thing you do normally is Fager maneuver. After doing the Fager maneuver and the thing continues, the ECG is still looking like this. Now what do you want to do? That's when you go to adenosine. But if this is there, you don't bother here. Just go straight to adenosine. What can trigger it? What could have triggered it? Stress, alcohol, caffeine. They take a lot of caffeine in US. Alcohol too, and the likes. So when they bring them, you can easily predict what is causing it. So that's just about this area that you want to rehearse for the exam. Like, discuss it with your friend. Say, if the patient is unstable, what will you give? If the patient is stable, what will you give? So discuss it, rehearse it, like do it like you are practicing for one concert. So that if at all the question comes, that rehearsal you are doing, it will come. Now that I bring up the question, you are solving question when you don't even know how to, you don't organize your thinking. In the exam, if at all they change something, you will miss it. Then we come to the atrioventricular reentry. If you look at it, this is not occurring at the level of the node. And that is when you talk about Wolff-Parkinson-White syndrome. You can't go into the exam and forget Wolff-Parkinson-White syndrome. It's a sin not forgivable under USMLE Step 2 law. It's cardiology. What will you say you chop? No one will forgive you. Even if you come out of the exam and be like, they gave me the question, but I forgive myself. They won't forgive you. See, mark it down. What do you want to take into the exam? The shape. Now, there is something you need to put at the back of your mind with respect to the shape. So you want to remember the delta wave and the widened QRS complex. Just look at what I put in box here. You can see in the course of having, what is delta? This is how we write our delta. Delta. This is delta. So that's delta wave. So it shows that when you look at your QRS complex, you should be able to bring out this delta. You can see this this way. You can see the way the thing is actually sloping upward or downward. Now you want to look at it here. You can see this delta wave. In the course of sloping up here, so the PR interval end up becoming shortened. This is the normal one that you should have. Look at the way they sketch it. This is the normal one. Now here it has become shortened. And when we were doing the introduction in cardio, you'll remember it's a short PR interval. They will ask you Wolff-Parkinson-White. So, and that's what you see. Then you see this delta wave. Then you can look at the QRS complex here. You realize that it's actually becoming widened. All right, so that's actually just what you will see here. So now in the ECG they will give you, you need to be very careful. Don't overlook and don't underlook. I don't know how to put it. Because look at this ECG now. If I say, can you see any delta wave here? Most likely, if we are not doing it, I just show you. Most likely you are going to say, no, I don't think there is any delta wave here, because you can't see it really distinctly delta in shape. Look at what they are putting here. See? Can you see? So if you are not very careful, you may not know it's delta wave. You just need to look well. Then check around those ECG. Once you see, just pick this delta wave and move out. All right, so that's just about this. Basically, these are the two you want to rehearse here. Now, the last thing you want to rehearse is what we call the the treatment. Now, they've given you the ECG, they've given you the story. They now say, what is the treatment? So if there is no symptoms, so you can only just observe. If there is symptoms, there is symptoms, you have what we call acute treatment. You have what we call definitive treatment. In the exam, most time they ask about the acute treatment. It doesn't mean they can't ask definitive treatment. They ask that too, but most time acute treatment. All right. So the patient is having it. So he's having the palpitation, he's having dyspnea, he's having dizziness. You see the ECG, Wolff-Parkinson-White. All right. For normal Wolff, this is a Wolff. For those that are, this is a Wolff. The first thing is, how is this Wolff sounding? Ooh, I'm not a Wolff. I may not be able to sound like them, but at least you can check online how Wolff sounds. Like they are proclaiming their mightiness or their strength. Ooh, so look at this proclaiming. Procainamide. You now see this. Will you stay? You will run. Amiodarone. Those are the two drugs for acute treatment. So these are the two you are looking for in the exam. Procainamide or amiodarone. Procainamide, amiodarone. Procainamide, amiodarone. The definitive treatment is that bundle that is actually shunting the wave of depolarization from the atria to the ventricle. What can we do to it? You call it bundle of Kent. So what can you do to it? You can ablate it. So radio frequency catheter ablation can be done. So, and that's how you can deal with this. So you must never give this patient any drug that is going to block the AV nodal conduction. The reason is that this is the heart, this is the node, this is the bundle of Kent. You now you give the patient a drug that is blocking this. Then most of the wave of depolarization that moves from the SA node to the atria, they will be shunted through this bundle of Kent because your drug has blocked the AV node. So therefore, when a patient is placed on AV nodal blocking agents like beta blocker, non-dihydropyridine calcium channel blocker, the symptoms will get worse. So you don't go and give them that drug. So the question is just, which of the following do you want to avoid in this patient? The answer is any AV nodal blocking agent. Avoid them. All right. So that's that about this. What about the atrial tachycardia? Atrial tachycardia. Basically, you just see the P wave, which is the atrial depolarization, is just going to come out more. What about the multifocal atrial tachycardia? So, what you will see here, and I want you to get the gist around it. The ECG will first of all help you out. I put an arrow because it has been tested before. So, the ECG is what you need to focus on. They will give you. What are you looking for in ECG? Just at least three distinct P wave morphology. Three distinct P wave morphology. Look at the P wave here. Can you see how dwarf this one is? Look at this one, taller. Look at this one. He's even looking like he's holding another one. Look at this one. Can you see the shape here? See the shape in this one. When you start seeing all manner of P wave morphology in the question, just go for multifocal atrial tachycardia until proven otherwise. All right, so that's what we'll see there. So now, what are the causes? So amidst what they are going to list, what do you want to pick? Never forget this, what do you call it? COPD. Actually, it's cardiopulmonary condition, but you can see this is the only one we are bringing in pulmonary condition here. So if you check the option for all your care, you may just be dealing with COPD. The other causes, hypoxemia, congestive heart failure and the like. So you may see, but never forget this is most likely going to be under the COPD. So what about the treatment? Treat whatsoever the underlying condition is. Then for the acute management, intravenous non-dihydropyridine calcium channel blocker and beta blocker, because they will just block the AV node and reduce the conduction. Then if at all is recurrent and for symptomatic management, so more or less like after acute management, what do you want to continue with? Oral form of the same drug. This one, acute management, is intravenous. The recurrent or further management is oral. So now when you are going into the exam, we know that you are in hurry. We know you don't have patience again. In fact, you just want to solve all questions you have in the world. And still relax. Pick the point. Because in the exam, some people have gone into the exam and you just come and be like, the question does not look like this. Does not look like this. Does not look like, because what everybody was just busy is just solving question around. Carry your first aid. Pick the point, because the way they will frame the question, it is only your understanding that can make you to predict them. And first aid never change what they've been writing, because they won't change it. It's there in the exam. It will show. It will speak. At least you will know something that you want to think about. You see the ECG, just be like, are they asking me about the diagnosis? Because I will be looking for a pulmonary cause. Is it the treatment, acute management? Just be like intravenous. I remember that guy shouting intravenous, 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 because they will show you intravenous non-dihydropyridine calcium channel blocker. Oral, that's option B. Non-dihydropyridine calcium channel blocker. Put on some other stuff. If it's acute, intravenous. If it's recurrent, symptomatic, oral. What about the ventricular tachycardia? There's nothing here you don't know. So we have what we call premature ventricular contraction. We have premature atrial contraction, the two of them. What you need here is the shape. That's actually the basic thing you need here. You just need to note the shape. Call me 1 minute, please. Sorry. Lovely. It doesn't change. USMLE does not change. This is step 1. The same thing happens in step 2. So you can predict what they will test in the exam. You see, for premature bit, we have the premature atrial contraction, premature ventricular contraction. All you need is just the shape. All you need. Like once you know the shape, that's first thing you can be rest assured that okay, you will do well. Because they will just give you the ECG. This is the shape. You will just see, look at this one, look at the premature ventricular contraction. You can see this sudden, can you see this wave here, the way it is? And that's how the ECG will be given. It does not change. So your answer will go for premature ventricular contraction. So what you have in the premature atrial contraction is actually this P wave. And immediately after the P wave, you know that QRS complex will follow it. It's not supposed to be, but it's just going to come up. Do you get it? So the question, they will give you the ECG, or they mention it that the patient has premature atrial contraction on ECG was seen, blah, 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 and the line. That's which of the following is the likely cause, or something like that. Or the patient is consumed that. You say on ECG they are seeing the premature atrial contraction, or they give you the ECG. Now say, what's the best next step? The best next step is just to advise this man, please can you reduce your caffeine consumption? This is the most tested concept in step 2. This caffeine consumption. This word, this is the most tested. People consume caffeine like anything. They consume like that's their water. So note it very well. The same thing for premature ventricular contraction. So they can also have it from caffeine, but most time is related to premature atrial contraction. They can also have it with respect to the premature ventricular contraction. Please just watch out for this being tested. First aid is specific. So in the exam, they can bring it out. So premature ventricular contraction, note this shape. So can you see decrease caffeine and alcohol consumption? That's all they will test. That's what they will test. Just decrease. That's the word. You just read the question and be like, decrease it. You go and reduce your alcohol that you are drinking like water, and the patient will be better. And this is the question. This is the answer. So please watch out. If symptomatic, it's very bad after even advising the patient or stopping this, or when the patient is coming, the patient is having a lot of symptoms, you may want to give the patient beta blocker. So or occasional other antiarrhythmic, but you can see my arrow here is quite thin because this is the main thing they want to test in the exam. All right, so please watch out for the shape. Note the caffeine and alcohol consumption reduction. What about the ventricular tachycardia? This is the ventricular tachycardia. How will you know this ventricular tachycardia? You can see all these QRS, they are widened, and they are tachycardia. This does not look like the supraventricular tachycardia. This is the supraventricular tachycardia. Can you see narrow? So it's above the ventricle. So this is it. Can you see? All right. So what about the treatment? You've seen this. So before the treatment, what are the causes? Coronary artery disease, MI, structural heart disease, and you don't need to cram it. Whatsoever the patient is having will be there in the question. And they will now give the ECG if they want to set question on it. So the next thing they will now ask is what's the best next step. Now, for that best next step, you check, just quickly go back to the question. Are you stable? Are you not stable? If the patient is stable, lap. If the patient is unstable, cardiofascial. Is the patient stable? Lap. Unstable, cardiofascial. Now, with respect to the unstable one, we are also still going to look at the pulse. So, but wait, look at the stable, the same drug you use for Wolff-Parkinson, right? Syndrome, can you see? So you are just adding lidocaine to it, amiodarone procainamide. So for those that are not stable, they will give you the ECG, they will just check the question. Once you are seeing all manner of symptoms, you say, this patient is not stable. So for those that are not stable, you just check, do you have pulse? The question says that, okay, when on physical examination, they can palpate the pulse. The answer is synchronized cardiofashion. You can only cardiofat. If at all the patient is actually having the pulse. So please never forget that. Then pulseless, if your patient is having and is pulseless, so then you need to defibrillate. You will see, I will still bring this up again. You defibrillate. They will put two of them amidst the option. Once it's pulseless, defibrillation. Okay, relax. You're like, how will I remember? Okay, let me show you. When you want to do CPR, you start your CPR when you can't really palpate the pulse. So if I thought you now do, you can't really still pick anything. I have check the pulse. I have give this. I have give that. It's still not there. It's that at that moment you start thinking towards defibrillation. All right. So please never forget that, just for you to have an idea of how this can be tested. So pulselessness, defibrillation. Because if the patient is having pulse, they will also put defibrillation. They don't go for it too. That would be wrong. Now, ventricular fibrillation. You are seeing fibrillating where they give something like this. Can you even tell us what the patient is? All you can see is that they are widened. And they are all irregular. They are just anyhow, aphasid. So no discernible rhythm. Ventricular fibrillation, not tachycardia. See the tachycardia? Can you see? Can you see the tachycardia? It has a particular wave. Fibrillation does not have. So if it's fibrillation, what do you want to do? This is the answer. This is what they will test. Defibrillation. And that's all they will test. What do you want to? Best next step. Just go and bring just defibrillate. Defibrillator. This is it. Once you see it, just give this. All right. So please never forget this. Because you can see it's a fibrillating wave. Torsade de Pointes. There is no one here that will say when I see Torsade de Pointes, I can recognize it. This is something that overemphasize. So let's see the Torsade de Pointes wave. You can see the way the wave is. So let us also check. So I just want you to flip through all those ECG and see, so that you have an idea of how. So they may give something like this in the exam. Can you see? Just something you can see, widening, narrow. Just see that alternating stuff. So once you see it, or wavy this thing, you know the way we normally draw wave when we're in secondary school. So that's how it's going to be. So once you see that, just be Torsade de Pointes. So another one is this. Can you see? It's coming down, it's going up. Is another one. Can you see? Widen here, narrow there, widen, tall here. So something like that. So when they bring them out, you don't say I don't know. It's Torsade de Pointes. Can you see? The same thing. So there is nothing there. Just note the shape so that when they bring them in the exam, you will know that you know. All right. So that's basically Torsade de Pointes. What are the causes? Hypokalemia, hypocalcemia, hypomagnesemia, hypo this, hypo that. So don't forget them. All right, Torsade de Pointes, and we related it to long QT the other time. So please don't forget, in case that's tested, and the congenital one, don't forget long QT syndrome. So with this now, if the patient is not stable, can you see? Synchronous cardiofashion. If the patient is pulseless, defibrillation. All right, so that's just by the way. So these are the mechanism of tachyarrhythmia. So you don't need to give yourself a headache because you already have an idea. The re-entry, you already have an idea. So this is what is happening at the level of node. So that's for the AV nodal re-entry tachycardia. So you can also have triggered activity. You can also have abnormal automaticity. So that's just that. All right. And this is atrial fibrillation. What do you want to take into this? I know you know atrial fibrillation, so this is not to teach anyone atrial fibrillation, but just to show you how you want to be reasoning things out and be like, okay, when I see this, I think like this. Oh, this is the first thing I will look at. I will look for this, that. That's the basic point we are trying to make. Let me check my people. Are we sleeping? Are we asleep? Is anyone awake actually?
Sure.
Yes.
All right. So just to be sure we are awake, because most time people sleep off after sipping 2 or 3 cups of alcohol. So this is atrial fibrillation. How do you want to be looking at it? First, irregular pulse is going to be in the question. Still relax. It doesn't mean that anytime it has irregular pulse, you have atrial fibrillation. But that's just one of the causes that you want to be thinking about. So then the reading they are also going to give, you know that you are not going to see the P wave there. And there is another condition I have mentioned so far, that you are also not likely going to see the P wave there. So we remember the name of the condition. I mentioned it in relation to this. Supra what? Supraventricular tachycardia. Do you remember?
Yes, sir.
Lovely. So please don't let us forget the two of them. All right. So now, how do you want to be looking at atrial fibrillation in the question? At least if I say, let us say one or two things on atrial fibrillation, everyone will say something. All right. So the first thing is the risk factor. United States Medical Licensing Examination Step 2. You enter into the exam. What's the risk factor for this thing? There are some guys, I will show you that you first of all rule out. After ruling them out in the question, you now see what's the risk factor here. The thing you must be thinking about until proven otherwise is hypertension. Hypertension. They are like, Mr. Hypertension, how come everything is hyper? You said because it's a very silent killer. Hypertension. The patient may only just be hypertensive and they are picking irregular reading. You now say, what is the risk factor? They say the diagnosis of atrial fibrillation is made. What is the risk factor for this patient atrial fibrillation? Just flip through the option and pick hypertension. I'm emphasizing it like this so that when you get into the exam, first thing will first of all come to your mind. Be like, hypertension. Is it this heart failure? Yes, they can ask it, because when we get to heart failure, I may show you how that can cause atrial fibrillation, because anything that dilates the left atrium is definitely going to cause atrial fibrillation. In as one that heart failure can cause dilation of the left atrium, atrial fibrillation will occur. It's a matter of time. So when you see atrial fibrillation in heart failure, you are not surprised. But the commonest presentation is someone just suddenly developing atrial fibrillation. They don't know. It's not having heart failure. It's not having this. They are not like, what is causing it? Hypertension. Please watch out for these guys. They will test it. That's the risk factor you want to put at the back. The others are increased age, valvular disease, and the like. Now, in USMLE and first aid, when you see them arrange things like this, most of the time it's actually in order with which you need to note them. So when you check that question and you check for hypertension is not there, just be very sure that, this is not about the age of this patient. Do you get me? Please just watch out for that very well in case that's given. The other causes, they are this obstructive sleep apnea. They are the one they will test. Obstructive sleep apnea. You will just be seeing all those pictures. If I thought they put whatsoever that is causing it there, you will see it. Obstructive sleep apnea, pulmonary embolism, chronic lung disease, heart failure, coronary artery disease, and the like. So you just put them there. You will know that, okay, this is actually what is causing it. So that's the risk factor. So you can call your friend and be like, let's discuss around the risk factor. So you can easily have an idea of what they will ask. Now, anytime you see a question that is related to atrial fibrillation, until proven otherwise, the first thing you do is to exclude she. I say there, she must be excluded. So someone call you on phone, you are the newly matched and this thing, and you're like, there is someone here, and you have a patient too, and we notice that the pulse is irregularly irregular. You just quickly ask question around she. Do you think that patient is taking any substance? Is it no? We've asked. Do you think, can you see any picture, any features, any sign of hyperthyroidism in the patient? They say, yes, we can see. That is the cause. You check. Please, can you quickly take the electrolyte for me? What do you want to check? Because most of the time, what is causing the atrial fibrillation might just be electrolyte abnormality. You just want to realize, what are those substances? One of them is this caffeine. Caffeine again. It might even just be caffeine. So, did you recently take caffeine? Yeah, I just took caffeine. All right, so that's just by the way. Just don't forget this she. you must exclude them in the exam. So when you are reading the question, the way they will put the question is that the patient have this atrial fibrillation. They now say the patient is not on any substance. The patient TSH is normal. Electrolyte is also normal. So she has been excluded. So you now be like, oh, they've excluded. You now start thinking about which other thing could have been responsible for this patient atrial fibrillation in that question. All right, so now you've seen the significance of it. So when you are reading your question, don't say you don't know. She must first of all be excluded. So what about the pathophysiology? Pathophysiology. The pathophysiology of atrial fibrillation is actually related to pulmonary veins. Pulmonary veins empty into the left atrium. So the cells you see around them, they are the ones that usually cause the atrial fibrillation, and they can actually be overstimulated either with the distension of the left atrium or by one substance or the other. So that's that. Just don't forget it's related to irregular depolarizing cells near the ostia of the pulmonary vein. So if I thought we want to treat it definitively, we just need to go and bring our ablating stuff and just kill those cells around those pulmonary vein ostia. So once we kill them, the patient should be better. So now, how do you want to classify? You are not going to the exam to be classifying anything. You are not. Even though the questions will classify it. And when you see it, you can easily say that, okay, this is more or less like, what do you call it? Recurrent. This is paroxysmal. This is persistent. You can easily see. So persistence is when it is more than 7 days. Long-standing, when it's more than 12 months. No one will ask you all these things. They are just there. So new onset or recurrent, you will see it. When you know that this is the first time the patient is having, or this is second or third time the patient is having it. And they are usually, and paroxysmal usually self-limited. It comes, it goes, it comes, it goes, it comes, it goes. All right. Dr. Omowumi, you wanted to say something?
I don't know. Yes, hi, Dr. Festus. Right. Sorry, I had a question. For the AF, the definitive management is the pulmonary vein osteoablation. Yeah. That's after the acute event has opened and they are stable. That's when you take them for that.
Yeah.
Okay.
So that's that. Where did I get to? Okay, I think what I was talking about is this. Okay, now look at the history. How will I now know? When I read the question, I will now be like, oh, this is atrial fibrillation, this is atrial fibrillation. You just see they can give the ECG without any P wave, and the patient may not be having chest pain. Because when I read the ECG and I'm seeing P wave, I'm not seeing P wave, and the patient is complaining of chest pain, I'll be like, hope this patient is not having supraventricular tachycardia. But I check the question, the ECG is not showing any P wave. One of the things, and there is no chest pain. They can have chest pain, they may not have chest pain, but in supraventricular tachycardia, they are most likely going to have chest pain. So if I do not see chest pain, I'll be like, atrial fibrillation, atrial fibrillation, atrial fibrillation. So please don't forget. And the reason why I'm emphasizing that is that the answer may actually be supraventricular tachycardia, and you are shouting atrial fibrillation too. So child, don't forget it. So they may have palpitation, fatigue, dyspnea. Sometimes chest discomfort or even syncope may be there. All right, so that's just by the way. Then irregular pulse, irregular jugular venous pulsation, you will see it. So let us see the way the ECG will look. Can you see? So this is ECG. And when you check it, it's not regular. So irregularly irregular. All right, now I put something here. If that atrial fibrillation is due to hyperthyroidism, that's what's the best next step. You just go and measure the TSH. Wait, you say it's due to hyperthyroidism. Yes, of course. How did you know it's due to hyperthyroidism? Because they will put symptoms and signs of hyperthyroidism in the question. So they will put symptoms and signs. Just be like, okay, best next step, TSH. That's your this thing. So what about the treatment? A, B, C. Now, the next thing you want to note about step 2 is that it's not about the drug you cram. No. They will list all the drug that you've ever known about that condition. What they test is orderliness. That's the exam. It's not about, someone is mentioning beta blocker. Yes, you can give it. Antithyroid. Yes, you can give it. No. Nope. That's not it. It's orderliness. So when you start studying, you notice the order. If there is a mnemonic, you can say, what is the first thing? That's why they say best next step, not what do you want to do. So that best next step, you must know. So the first thing you want to, the best next step will be the treatment, also the orderliness. So antithyroid to generate the sinus rhythm. Most time they don't test this antithyroid. You just go straight to the beta blocker to reduce the rate. So if it's due to hyperthyroid, just go for beta blocker. So note it very well. Last resort is cardioversion. If after doing this, the patient does not get better. But that's just by the way, it's just a point I needed to bring out. So this is the lab that you were telling the patient, the nurse on phone, get this ready. Electrolyte, complete blocker, TSH, this one. That's what you also rule out the shit. All right. So transthoracic echo, because it may be due to a structural heart disease. So maybe mitral stenosis. Because if the patient is saying, I don't take any substance, no, they check the TSH is normal, electrolyte is also normal. What else could it be? You check the patient, you can't really bring out anything. Then most likely maybe you are dealing with a structural problem. You now be like, go and do echo. Then I'll do the echo. They say, yes, the patient is having mitral valve stenosis. You see, yeah, that's the cause. So because blood is not emptying very well, the left atrium now dilate and now give the patient what? The atrial fibrillation. Now, the patient now, you're already shouting, yeah, okay, you are now calming down. This is atrial fibrillation. The next question is, doctor, now that we know that this is atrial fibrillation, what do we want to do? What we want to do? So stroke prevention. Now the first thing, the first goal. This patient must not throw an embolus. This patient must not throw. This patient must not develop stroke. This patient must not develop stroke. This patient must not. That's the first goal. First goal that they will tell. Best next step. You read the whole question. The only thing they've done is to diagnose it. Now the best next step. This is the best next step. We'll just prevent this to prevent the stroke. So what do you want to give? You want to give the patient anticoagulant. So how are we going to give the patient anticoagulant? They normally use this Charles-Vaz score. So I usually call it Save Charles. Let's save Mrs. Charles from stroke. That's what I call it. I don't need to be correct, but I just say, let's save Mrs. Charles. Okay, doctor, what do we do now? I say, okay, let us save Mrs. Charles from stroke. So you can just write out the S there may be the sex or stroke itself. A is the age. You have two ages here. So one of them is 75 and above. The other one is 65 to 74. So then C is congestive heart failure. H is hypertension. A is the second H. D is diabetes. The S there is the sex, as if being a female. So that's the child. So you can just say save Mrs. Child from stroke. It's just a joke anyway, but if that makes sense to you, use it. If it doesn't, so the reason why they put this like this is just for them to, that's what they could come up with anyway. So anyhow you want to, child, use the Charles-Vaz score so to know the whether the patient will benefit from anticoagulant or whatsoever you are dealing with is actually truly atrial fibrillation. So just for you to know this risk of stroke in a patient with atrial fibrillation. So if you are getting at least 2, maybe you get 2, you see 3, you see 4 in men, or at least 3 in women, please go and give the patient anticoagulant. Now, the question is this: in the exam, you don't have time to write down this. You don't have that time, but definitely every question will start with the age. A 75-year-old woman presented with this, blah, blah, blah. Quickly look at that age. Oh, this woman is 75 and above, or 76. 2 score. Quickly check the, the BP. You can devise a way you want to be looking at your stuff. Check the BP. Is it normal? You can say hypertension. You just see those 2. You have already brought out 3. Give anticoagulant. So you see the age and you now check the past medical history. The patient is diabetic. The patient is, comorbidity, the patient is diabetic, having hypertension. You can see the score is already rising. You can see them. Just go and pick. Give the patient anticoagulant. So just look at it and give the patient anticoagulant. So which anticoagulant are they going to be tested in the exam? So these are the anticoagulants. The main one you know. Direct thrombin inhibitor. We usually call them bad guys. They are the ones that can tame thrombin, for those that did step 1 with us. So you see the simplicity of I think that should be hematology. Yeah, hematology there. So direct thrombin inhibitor, then activated factor 10 inhibitor. So for the activated factor 10, you'll be seeing XA in the name. So rivaroxaban, apixaban. So for the direct thrombin, dabigatran and the likes. All right, so don't forget this guy. So that's that. Another drug that they use is warfarin. So warfarin, direct thrombin inhibitor, activated factor 10 inhibitor. So any of them will be in the answer. Just any of these guys will be there. You just pick your answer and go. But most of the time, warfarin, they only give it to them if what is causing it is actually due to valvular problem, like mitral stenosis. That's when they give warfarin. So in case you are seeing warfarin, you are seeing dabigatran in the option, you're not like, they've confused me. Which one do I pick? Just check. Is it valvular or not valvular? If it's valvular, warfarin. If it's not valvular, then you can give the other drug. All right, so that's just by the way. So please watch out for this. That's the first thing they are going to test in the exam. So the second place where you are expecting question on atrial fibrillation is with respect to the stroke prevention with device. How can we prevent stroke with device here? So there is a particular part of the left atrium that you must note where the blood is going to settle there, and if it settles there for a long time, so you start having some thrombi being formed, so or clot, anyhow you want to look at it. So you call it left atrial appendage. So let me show you the left atrial appendage. I know you know, but let me still show you left atrial appendage. So this is the left atrial appendage. So this is the left atrial appendage. Can you see? Just this area. Okay. So it's also the same thing here. Can you see it? All right. So that's just, this is another one, left atrial appendage. So blood can easily go there, settle, and some clots can be formed. All right. So that's just by the way. So please note it. So sometimes for all you care, the question might just be related to you actually what do we call it, occluding the left atrial appendage. So when you occlude it, so no blood will go there to settle again, even if the patient is still having atrial fibrillation. All right, so that's just that, in case that's what they test, but that's just as an alternative to anticoagulants. So you ask this patient, is there any reason why we should not give you direct thrombin inhibitor? He say yes, you can't give me. Maybe you recently had a surgery or something like that, and you can't give anticoagulants. So another thing you can do is this left atrial appendage, and just go and occlude it. So look at the rate control. So how can you control the rate at which the heart is actually depolarizing or contracting? So we can control it with medication. We can control it with procedure. So, all right. So with medication, which drug do you want to give? These are the two drugs that just for you to have an idea of as you are going to the exam: beta blocker, non-dihydropyridine calcium channel blocker. All right. So if this patient is having grave disease or hyperthyroidism and I want to give a drug for rate control, beta blocker. If I'm dealing with COPD and I want to give a drug for rate control, I won't give beta blocker, because the patient is going to develop more symptoms unless the beta blocker you want to give is cardioselective. All right, so the beta blocker, instead of you just giving beta blocker, you rather give non-dihydropyridine calcium channel blocker. So that's just how they can play around these guys, just the medication to control the rate. What about the procedure? The procedure is just AV nodal ablation with implantation of the pacemaker. So that's what you can do. You can ablate the AV node so that those depolarizing waves are coming from the atria, they won't be able to pass through the AV node. So that will control the rate. So now look at the rhythm. You say, rate, are you control? You say, yes, I'm control now. I'm now 108. I'm now 105. You say, oh, that's better. That's better. So, but what of rhythm? Say rhythm is still doing abnormally. Come and see the rhythm. We still do not have P wave. We do not have P wave. You say we don't have. How can we do this? So, how are we going to control the rhythm? We have what we call electrical cardioversion. We also have pharmacologic cardioversion. We have catheter ablation. So, you say we are going to cardiovert you, Mr. Shit. You say, okay, doctor, just help my life. It's either you use electrical, you use pharmacologic, or you use catheter ablation. All right. Now, how will you know the one to go for? You now quickly check. Is this patient unstable? If the patient is not stable, you go for immediate electrical cardioversion. Immediate electrical cardioversion. Electrical. Because in the question, they will just put electrical, pharmacologic, the catheter ablation. You are like, I've seen all this stuff. 3 of them are in first stable. Which one will I choose? Just go for quickly check, is the patient unstable or not? If the patient is not stable, you go for electrical. Because you may not even see the vein. You may not even see the patient is completely not stable before the patient will die. So electrical cardioversion. If the patient is stable, you can use electrical too. Do you get me? Then you can also give the patient the anticoagulant. So please just watch out for this. Now, with respect to the anticoagulants you are going to give to the patient before the procedure, that's now what we want to look at. Don't forget that the patient has been given one anticoagulant before to prevent stroke. Now you want to do the procedure for the patient or do cardioversion for the patient to correct the rhythm. So which anticoagulant do you want to, how do you want to focus on? How do you want to analyze that in the question? You now quickly check, for how long have you been having this your atrial fibrillation? You say it's already more than 48 hours. So there is a more time for stasis. So that shows that the risk of thromboembolism is very high in this patient, because it's more than 48 hours the atria has been fibrillating, and they were not contracting. All right. So you first of all give the patient 3 weeks of anticoagulant will be given before you cardiovert, because you do not want the patient, because once you cardiovert, the atria will be contracting better. So whatsoever that is already settled, clot that is formed and the like, they will be dislodged, and the next thing you hear is that the patient you claim that the patient is now stable, can now go home, has already developed stroke. So you need to be very careful. So that's why you give the patient, they will test it. You just say, what's the best next step now? You just quickly check, for how long have you been having the atrial fibrillation? It's already more than 48 hours. Please, we need to give you anticoagulant. That's what they want to test. If it's less than 48 hours, most time you just check. Just weigh the risk. If I thought there are some other risk factor there that may also make the patient to develop basically the thromboembolic risk is very low if it's less than 48 hours. So you may actually cardiovert without prior anticoagulation. But once it's more than 48 hours, you need to put the patient on anticoagulant for like 3 weeks before you cardiovert. They will test it in the exam. It is where we test it. You'll just be surprised that, wow, they gave me question there and they mentioned the duration. I just gave anticoagulant before cardioversion. A, B, cardioversion. C, cardioversion without anticoagulant. D, cardioversion later. You just look at which one do I choose. It is your understanding that will make you to pick correct answer, because you won't remember much. The story around it is what will help you. And that's that. So which anticoagulant are we going to, now that we say, okay, now we need to give the patient anticoagulant. So which anticoagulant do we want to give? If we are dealing with valvular problem, warfarin again. Warfarin. If it's non-valvular, you can give the new oral anticoagulant. You can give warfarin if you like. You can give IV heparin. You can give low molecular weight heparin. Any one of them. So please just watch out. If it's valvular, warfarin. Only warfarin. You don't give. So they will list all those ones you know too. Dabigatran, rivaroxaban, or apixaban, warfarin. And you now check. I have all of them here. You now check. Then I realize that it's mitral stenosis that's even causing it. Your answer will now become warfarin. Okay, what about the pharmacology cardiovascular? You can use any of these drugs. Flecainide, propafenol, dofetilide, amira, and less. The ablation you want to do, you can just go and ablate the area around the pulmonary vein. So you can use that. All right. Another procedure that is similar to that is what we call Cosmace procedure. So just for you to have an idea, but no one will ask you any question on this. All right. What about another key facts here? Evidence of Wolff-Parkinson-White syndrome on ECG. You call for procainamide, not nodal blocker, for supraventricular tachycardia. So watch for that. So then avoid vasopressor in hypothalamic shock until adequate fluid resuscitation has been provided. So we'll be looking at this later. All right, so that's just about that. Let me quickly show you something about the cardiac life support basics. So, but not to be moving stuff. So they do it as a course, but you just want to pick 1 or 2 points. Put something at the back. Not for you to be like, I have certificate. I did a certification course on ACLS. This one. Oh, sorry, we've had you. But just for you to pick 1 or 2 points, basically, and go into the exam. That's all we need. So these are the arrhythmia, and this is just the treatment you just want to put at the back of your mind. So, but before we look at them, I just want you to look at this treatment of unstable tachyarrhythmia. If the patient has pulse, we just cardiofact. If the patient does not have pulse, is pulseless, we can defibrillate. Now you need to be very careful here. So pulseless electrical activity and asystole are not shockable reading. You don't shock this one, you don't defibrillate them. So all this pulseless electrical activity, don't go and once you pulseless electrical activity, asystole, because all these guys too, they also will not give pulse. Now relax, let me show you again. The basic point here is, do I want to do cardioversion? Do I want to defibrillate? Once you see pulselessness, okay, your thinking should be defibrillate. Yeah, that's good. At least you have a point. But you do not defibrillate pulseless electrical activity. You don't defibrillate asystole, because they also will give pulselessness. You don't go and defibrillate them. They are not shockable rhythm. Do not go for defibrillation. Because in the question, you will realize that the patient does not have pulse. Don't go and be shouting, defibrillate. You don't. But you can defibrillate ventricular fibrillation, pulseless ventricular tachycardia, not pulseless electrical activity, not asystole. You don't go for them. The treatment for these guys is epinephrine. So in the exam, they will now put defibrillate, option A, defibrillate, option B, epinephrine, option C, cardioversion, option D, shall put something there. So if you realize that the patient does not have pulse, your first thinking is defibrillation. You now check. Hope this question is not about pulseless electrical activity. Hope this question is not about asystole. You say, it's not about it. Then your answer is going to be defibrillation. If it's about these two, your answer will be epinephrine. All right. If the patient is alive and the patient has pulse, you go for synchronized cardioversion. Now, if you come back to what they put here now, so asystole, pulseless electrical activity. The patient definitely does not have pulse. Now relax. this patient just collapse or is in the just does not have pulse, you check for the pulse, you don't see the pulse. You know the way we used to do, help, help, help. Can you hear me? Can you hear me? You can check for the pulse. You can't feel the pulse. Sincerely speaking, you don't know what the patient is having. Anytime you do not feel pulse, you start CPR. You don't start CPR on someone you are feeling the pulse. What are you cardiopulmonary resuscitating? No, you don't. So it shows that technically, because you are going on the street, you just see someone collapsing. Mister, can you hear me? Can you hear me? Somebody help! Somebody help! 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 The next thing, you quickly check for pulse. You cannot feel the pulse. Initiate CPR. Now in the exam, they will just write the question, blah blah blah. This one, pulse. The pulse could not be, it's not palpable. What do you want to do? Initiate CPR. So this is the answer. This is the answer they are looking for. Initiate CPR. Initiate, because that's what we do normally. So it doesn't change actually. Initiate CPR. All of them. Initiate CPR. Initiate CPR. So you now be reassessing again and check. So, all right. So that's that. Initiate CPR. Initiate CPR. Initiate CPR. If the CPR helps the patient, that's fine. If it doesn't help the patient, you may want to initiate contraction of the heart with a drug, most especially for asystole and pulseless electrical activity. And which drug is that? Epinephrine. Can you see the way they ask their question? Whereas, with respect to these ones, you can, this ventricular fibrillation, where you are also not palpating the pulse after initiating CPR, they say, what do you want to do next and the likes, and the patient is not coming up, so you go for defibrillation immediately. Defibrillate, defibrillate, defibrillate. So, and this is where they are most likely going to stop in the exam. Which one do you want to defibrillate? Which one don't you want to defibrillate when you see pulselessness? We've given you the information. You can say that it's too little. Let's complicate it. Go and complicate it to any level you like. So what about these guys? Supraventricular tachycardia, atrial fibrillation, and the like. So most time when you read these guys, you feel the pulse will be there. The patient may not be stable, but the pulse will be there. So if the patient is not stable, electrical cardioversion synchronize. Cardioversion, cardioversion, cardioversion. That's the answer. Cardioversion, cardioversion, cardioversion. So, and don't forget, when you need to start considering anticoagulant, please never forget that. All right, so that's just by the way. Please let's note this. We've already checked for the treatment of supraventricular tachycardia, so don't forget it. Let me ask you a question. You look at the question, the patient has supraventricular tachycardia in summary. What's the best next step? What's the best next step? Supraventricular tachycardia. They've already said this is supraventricular tachycardia. Best next step. You check through the option. It's all about drugs. What's the best next step?
Adenosine should do.
All right, that's a very good one. That's a very good one. Adenosine, but that's wrong. You don't go for adenosine. I told you something that is all about order. Your answer is going to be the word Figure maneuver until proven otherwise. Provided the patient is what? Stable. So you just check. Like, we like, okay, first off, I want to check if the patient is stable. Do you get it? I want to check if the patient is stable. So if you check.
I thought you said it was just drugs option.
Yes, but even, okay, maybe I didn't say the question very well. So, but basically, you see that this is supraventricular tachycardia. The patient is stable. So the best next step is Figure maneuver. It's all about order. They will put Figure maneuver, they will put adenosine, they will put all those things you know. Even cardioversion will also be there. Amidst the option. You now see that all these things are treatment. Which one will I now go for? Remember, it's all about order. Order with which you do them. So the answer there, until proven otherwise, will be Figure maneuver. All right. So if the question says they've done Figure maneuver and it's not successful, the next thing you do is what? Adenosine. You now give the patient adenosine. If the question say the patient is not stable, you don't go for all those figure and no figure. You would rather go for what? Cardioversion. All right, so that's just by the way. But thank you so much, sir. Thank you, sir. So you can see the summary for the bradycardia in the exam. Which drug did we say they are most likely going to test for the bradycardia in the exam?
Atropine.
Atropine. So that's just by the way. So you can see cardioversion, synchronized cardioversion. You can see defibrillation, which is also called unsynchronized cardioversion. So don't forget pulselessness. When you see pulselessness, the next thing you initiate is CPR. Do you get it? You initiate CPR. If you now realize that you are dealing with maybe ventricular fibrillation, pulseless ventricular tachycardia, you go for what? Defibrillation. If it's pulseless electrical activity or asystole, you will rather give the patient epinephrine. So, all right. So this is synchronized cardioversion for the others because they are most likely going to have pulse. If you look at it, just simple thing you revise over and over. Ask your friend. It will now become part of you that congestive heart failure. All right, it's congestive heart failure. So let me allow us to go for another break of 15 minutes before we start developing arrhythmia. All right. So basically, this is the congestive heart failure. Trust me, it's not that maybe you don't know congestive heart failure. So all you just want to pick is basically what are they likely to be asking? Because if they give you heart failure in the exam, you can read the question and just say this is heart failure. But the question is not really that going to be straightforward. That you just read it and just be okay, congestive. Now go to the option and just pick congestive heart failure. So what are they likely to be testing? That's what we want to look at. All right, when we say a patient is having congestive heart failure, basically you are going to see something related to both right and left heart failure in the question. All right, so for the heart failure, generally you can classify it based on ejection fraction. Now I know that most times you don't really focus on ejection fraction. You shall know there's something called ejection fraction. So 50 and above is actually what is regarded as normal. I think 50 to 60 may not be too correct. So once you start having anything less than 50, basically there is reduced ejection fraction. So there is reduced ejection fraction. Basically, once you are having anything less than 50. So now we can take this anything less than 50 and just say 40 to 50. We call it something. So 40 to 50, you can call this one moderately reduced. While less than 40, we can say this one is actually reduced. So this is moderately reduced ejection fraction. 40 to 50, where both of them you can see they are less than 50, so that's ejection fraction. Reduced ejection fraction. Okay, so look at this heart failure here again. Everybody here knows that there is something called systolic dysfunction, or you should say heart failure with reduced ejection fraction. When you mention the word systolic dysfunction, what is systole supposed to do? Systole is during systole that the heart contracts and send out blood. So if at all there is now systolic dysfunction, it shows that contraction is not really occurring. So what will happen is that there will be a lot of blood that will be retained in the heart. Therefore, there will be reduced ejection fraction. So systolic dysfunction is the same thing as heart failure with reduced ejection fraction. Diastolic dysfunction. The heart is not really relaxing very well. So you can see this in a patient that's having heart failure with preserved ejection fraction. I know you still think that we are blowing grammar. What have you said? What have you said? Relax. So they give you a patient with heart failure. They never even mention anything whether systolic or diastolic. You just look. The question is so void of clinchers. The question is so void of clinchers, you don't even know what you're dealing with. Which one? You just see only heart failure there and maybe 1 or 2 points. They never even mention anything about ejection fraction. Just look at the age. Age. This patient is less than 65, most likely to be systolic. At least someone that is 65, you can still call them sister. Let me just use that anyway. Sister, Lagbaja. But, daddy, I'm just looking for a way to put it. The person must be old enough, or baba, something like that. Or yeah. So, diastolic, they are often more than 65. This might just be the only clincher in that question. Before you come and say, I don't understand the question. I don't understand. I don't even know how they are setting questions, because I bet it with you, those questions will not look like regular questions in the UWOD, MBME. This one, all those, they won't look like them. They don't actually. You just need to have enough clinchers with you. Because in the exam, you will be left alone with whatsoever concept you've imbibed and your God. That's all. If you like, finish your word back to back. But material like first aid and some other material, ambos, combine them, rehearse them very well. Like you will have enough concept at your fingertips. So the question might only be related to the age alone. Sister Lagbaja, maybe less than 65, systolic dysfunction. The other one will definitely be greater than 65. And that's that. What about the comorbidity you may see in them? So they are just here, dilated cardiomyopathy. Definitely is going to be dilated if it's not contracting. So valvular heart disease may be the cause, MI. If the patient is having MI, they don't have enough ATP to contract. All right, what about the physical examination? Systolic, letter C. What you will hear is S3. Diastolic, letter D. What we hear is S4. So they can't give you a question on heart failure and they will now mention S4 and you are now saying it's systolic. That is wrong. Anywhere you see it is wrong. So diastolic is S4, you hear in it. Systolic, you hear S3. How many points have we made here? Very simple points. All right. Because this one, another way they can bring out the question here, they will just give the story, blah, blah, blah. The patient has the symptoms and signs of heart failure. You now check the option. You are like, is this systolic? Is it that? So you are not sure. Now check the question again. Go to the examination finding. Is the heart, are they thinking that the heart is actually dilated? If the heart is dilated, likely you are dealing with systolic. If it's heart dilated, likely you are dealing with systolic. If the heart is still looking normal, likely you are dealing with diastolic. So they say they are picking the apex, the point of maximum activity. They are picking it around the mid-axillary line. It's dilated, systolic. Because this one is not contracting to push out the blood. So that's just by the way. So look at 41 to 49. This heart failure will moderately reduce ejection fraction. So 50 and above, preserved ejection fraction. So never forget this. So, all right. So how are you going to diagnose this? When we get there, I will mention it again. I put an arrow here because this is the point you will see in the question they will give you. So what about the left-sided heart failure you've seen before, right-sided heart failure you've seen before? How will I just differentiate them? If it's left-sided, you know, the back pressure is going to make a lot of fluid to be seeping into the lung. So there will be a lot of respiratory involvement or manifestation. However, if it's right-sided, enough blood is not even going to the lung. So back pressure is going to make the patient to have systemic venous congestion. So you will just be seeing a lot of systemic venous congestion like edema. Even the patient may even be having some hepatic congestion and the likes. So when you are seeing that peripheral edema, hepatomegaly, ascites, and you check the question, you are not seeing anything related to respiratory system, you are dealing with right-sided heart failure. If it's left-sided, you will be seeing dyspnea predominant. So it's just respiratory symptom you will be seeing there. So if you now check the question, is the both of them you are seeing in the question, you are dealing with congestive heart failure. All right. So this is just based on timing, chronic, it can be acute. All right. So this is the New York Heart Association. So classification, I just put must know here. It doesn't necessarily mean that compulsory you must just put that, you must cram this. If you can pick it, pick it. If you can't pick it, just drop it and go. Class 1 is just saying there is no limitation in activity, no symptoms with normal activity. So whereas class 2, they have some symptoms, slight limitation of activity, but anytime the patient is at rest, the patient is okay. So what of class 3? They have marked limitation of activity. They are also still comfortable at rest. What of class 4? At rest, this one are not resting again. So that's class 4. So you don't need to cram it. If you can pick it, pick. If you can, no one will ask you for which class of New York Heart Association is this. They don't ask that. They don't test that in the exam. Now, let's pick those stuff one by one. I just wanted to pick what they will ask in the exam, basically. Systolic dysfunction definitely will be hearing S3 as sound in the exam. I mean, we'll be seeing it in the question. Definitely the heart will be big. So and the likes. All right. So then definitely there is reduced ejection fraction. So the cardiac output will drop. So now, when the cardiac output drop, for those that did step 1 with us, 2 systems will quickly come into play to help and be like, the cardiac output, the heart is not contracting. It's not really contracting very well. Those 2 systems, they are sympathetic system, nervous system, and RAS. What will sympathetic do? If I ask now, what will sympathetic do? All of you will definitely say the same thing. Catecholamine will be released. They are going to cause increased heart rate. They will cause increased contractility and the likes. What will the RAS do? Okay. RAS is going to cause increase in circulating volume. It's also going to cause vasoconstriction by the effect of angiotensin 2. You see, aldosterone is also part of it and the likes. So you can imagine what these two. So all you want to take into the exam is that, okay, I shall know anytime the cardiac output drop, these 2 systems will be activated. You don't need to cram these guys here. Don't cram them. Just remember sympathetic tone and RAS. That's all. That's just remember that. So I put something here, heart failure, volume overload and reduced cardiac output. There is also myocardial stretching. Because if the blood is staying in the heart and they are not being pushed out, the heart will dilate. So you say they stretch out. So there is myocardial stretching. So what's now the effect? There will be reduced perfusion, because if the cardiac output is reduced, there will also be reduced perfusion, and there is also reduced baroreceptor firing. You now have RAS and sympathetic nervous system activation. What will the RAS do? Vasoconstriction and salt and water retention. What will the sympathetic nervous system do? Increase contractility, increase heart rate, vasoconstriction. They will do the same thing. So what do you think all this thing will do? All this vasoconstriction, increase, they are supposed to compensate for the reduced cardiac output. So they are supposed to help with the perfusion. However, if they continue for a long time, they worsen it. Because with the salt and water retention, more salt will be thrown into the blood, water will follow, more blood will flow, preload will increase into the heart, and the heart is still not contracting very well. So the heart is shouting, I'm having headache, and you are still loading load on it. So before you know, the heart will just collapse completely. So they worsen the heart failure. All right, when they worsen the heart failure, you say, when they are still helping with the heart failure, you say it is compensated. When they now start worsening the heart failure, you say the heart is decompensating. So when they are still helping out, compensated. When they are no longer helping, they are just worsening it, decompensating. All right. The stretching will do something. The stretching will release AMP, BMP. That's what the stretching will do. You know, when there is stasis in the heart, they stretch out. You now see AMP, atrial natriuretic peptide, brain natriuretic peptide. They will both be released. What will they do? You say natriuretic, then they are throwing out sodium into the urine. So if they are throwing sodium out, it's more or less like they are negating the effect of aldosterone or RAS. So they are negating the effect of aldosterone or RAS. Oh, we now look. I was one of the cardiologists then. It's just a joke. I'm not any cardiologist. Just like, okay. Now that we have these guys negating the effect of aldosterone, because aldosterone is bringing sodium into the blood, and AMP, BMP, they are throwing the sodium back into the urine. That you want to kill this patient. You want to kill this patient. Another thing they do is that they cause vasodilation, while the RAS is causing vasoconstriction. We now look at the beautiful work these guys are doing. We say, okay, they are the father of what we call aldosterone escape mechanism. Aldosterone escape mechanism. The effect of aldosterone, the patient is escaping it because AMP and BMP are in the system. So because of this, because we look at what they are doing, their beautiful works, all we need to do is to raise the level of AMP and BMP. So if we raise the level of AMP and BMP, this patient will be better. All right, let us meet our minds if we are in this nice place. So that's for this, they end up improving in heart failure. So this is just for you to have something to think about, so that when you read the question, you just be like, this is where this question is going to. You don't cram anything here. Don't go and be cramming this chart. You don't need it. Just look at it like this. Reduce cardiac output, reduce perfusion, RAS will be activated, SNHs will be activated, salt and water will be retained, vasoconstriction will occur, there will be increased preload, there will also be increased afterload from the vasoconstriction. All right, now what are the drugs that can reduce mortality in the exam that they will test? What are the drugs that can reduce mortality in the exam that they will test? So the drugs they will test, basically, they are just the drugs that can counteract this SNS and RAS in the exam. That's all. So you don't even need to cram them. You just need to look like, okay, for the RAS, we should have a drug that will ACEI. Yes, it will be there. ARB, yes, it will be there. Neprilysin inhibitor, it will be there. Beta blocker for sympathetic, it will be there. Aldosterone receptor, it will be there. Just for you to look at the options and pick something related to these guys. Hydralazine and nitrate can also be there, but this is actually more of what I have mentioned before. All right, so and that's that. So that's just all you see here, the notes they are putting here. Heart failure with reduced ejection fraction, sympathetic nervous system activation, RAS activation. So how will I know? Don't forget, the patient, you will be seeing they put positive hepatojugular reflux there, which you agree. Peripheral edema is there, S3 gallop is there. This S3 gallop will quickly give it out. So there is a concept you should expect in the exam that they will test. They will test it. They will test it. Is the concept of hyponatremia. So this patient has heart failure. You've looked at it, heart failure. They will give the story heart failure. They will now go to electrolyte urea and creatinine. They now give you the electrolyte urea and creatinine. Now put the sodium is low there. You will realize that the sodium is low. It's less than 135. They will now say that which of the following is the likely predictor of mortality in this patient? The predictor of mortality in this patient. You now quickly check the question. You just say hyponatremia. Your answer is hyponatremia. It has been tested before. I'm talking about it in the real exam. It has been tested before. Tested. So that's why first aid, So how do you make the diagnosis? Best initial test. Echo. If you hear someone has heart failure, will you have requested go and do chest X-ray first? Echo cardiogram. And it's transthoracic echo. Because we have transthoracic, we have transesophageal. Transesophageal will pass through the esophagus, transthoracic through the chest. So, sorry. So it's the transthoracic echo. You see this ECG, they are most not likely going to test you on it. Chest X-ray, most likely they are no one will ask anything. You see this echo, expect it in the exam. Just what's the best next step? What's the best next step? Echo. Just pick echo. It would be wrong for you to be shouting ECG, chest X-ray. So some people can just call me and just when they get here, just do like this. That's okay. I don't need these ones. Echo. You limit how much jargons you put in the head. With laboratory finding, are they going to put in the exam? Shit. You forget brain natriuretic peptide. BNP. Let me show you how they will test it. When they give the heart failure and the likes, or they just tell you the patient shall have one symptoms and the likes, they will now say brain natriuretic peptide is 600, is 650, is this. You just realize that it's high. Just go and miss all the options. Your heart diagnosis heart failure. Even if you are shouting, you think this can be. The answer is heart failure. Pick it. That's the answer. Heart failure. Just by seeing brain natriuretic peptide very high. Alright, so that's what you need to revise very well. This brain natriuretic peptide. So echo, brain natriuretic peptide. You see the complete blood count. Creatinine, all this one that creatinine is high from hypoperfusion. So the sodium can actually be low later and is a predictor of what? Mortality. Can you see? Very easy and straightforward. All these TSH, T4 and the likes, they can be high, they can be low. So don't really bother yourself much about the other detail. So now what is the treatment you want to take into the exam? The treatment, you need to check the patient. Is the patient wet? Is the patient cold? I put something here, address perfusion before wetness. So P, when you write letter A, B, C, D, E, F, G, P, you get to P before you go to W. Perfusion before wetness. So in the exam, the first thing you want to really look at is how is the perfusion like? If the question says the patient is cold on examination, perfusion, the patient is having perfusion problem. That's your first thing. Do I quickly focus on this perfusion? Just quickly check the systolic blood pressure. If it's low, this is where your treatment will start from perfusion. And you first of all give fluid until proven otherwise. Now look at it. The answer to that question is all about fluid, but you are thinking about drug. Misuse of concept. So you look at the question, the patient has heart failure symptoms. You check the question, you realize that the limbs are cold or the patient is cold and the likes. So you are thinking towards something like perfusion problem and the likes. So immediately you see that, you're like, okay, there is a perfusion problem here. I need to quickly address. That's the first thing I want to address. Quickly check the systolic blood pressure. If it is less than 90 millimeter of mercury, then you start from this. So what do you want to give to the patient? I'll show you. So let us go stage by stage. You check here, You check for perfusion, you check for wetness. They say the patient is warm, but when they listen to the chest, the patient is, they are picking crackles. It shows the patient is wet. Crackles. So wet. But when they check the patient is warm. So it shows that the only problem the patient is having is wetness. What can we use to remove fluid from this patient? You say diuretic. Give me diuretic. Give me diuretic. You just give, our answer will be diuretic, but you usually give it with vasodilator too. So diuretic, just don't forget the diuretics. So you check the question. The patient has heart failure, brain natriuretic peptide high. You say heart failure. You now check the limbs. The question will say it. They listen to the chest. They say no abnormality. Brain natriuretic peptide high. So you say the patient is dry. The patient is warm. What do I now give? You don't give anything here. You don't give anything. Nothing. Likely the patient had heart failure. The patient is already being treated. The patient is now in chronic heart failure. Relax. You see that heart failure that you know, when you treat acute heart failure, you are just converting it to chronic heart failure. When the patient is admitted to the hospital, they brought the patient in acute heart failure. The patient is now going back home. Now say, doctor, thank you so much. You hug the doctor, hug the matron, hug everybody. Thank you so much. Yeah, we thank God. So, you can go home now. It doesn't mean the patient does not have heart failure again. The patient is just likely having chronic heart failure now. So chronic heart failure, most of those symptoms and signs you see in heart failure, you won't see them, but it doesn't unlabel them as heart failure patients. Even though the patient is better, even though you look at the chest X-ray, you are not seeing all manner of pulmonary edema there. You are not seeing them. Everything is looking okay. These patients still cannot run like Toby Amuson. These patients still cannot fight like Mike Tyson. Because once heart failure patient is always going to be heart failure patient. They might not just be in acute failure, but they can't do most of what they used to do. So you see dry and warm. Whatsoever drug the patient must have been placed on, you just say continue. So optimize the oral therapy. Continue it. So that's this. So now look at the question here. Look at the next one. The patient is wet. They listen to the lung, they are picking crackles or having edema. Now, the patient is also cold. So this patient is having wetness, is also having perfusion problem. So I want to quickly address perfusion problem before going to wetness. So I will now quickly check the systolic blood pressure. Is it less than 90? If it's less than 90, I know that I need to quickly focus on it. All right. So if it's less than 90, I'll quickly focus. That's when I know that there is a perfusion problem here. So what do I want to give? So what you are going to give here is dependent on whether the patient is wet or dry. Your first line should be fluid, but you check the question, you realize that this patient is also wet. Don't let me give fluid again because I may worsen it. You now first of all give the patient ionotropic agent. So the ionotropic agent is going to help with It's going to help with the contractility and the likes for the heart. So the stroke volume, cardiac output will improve, and that will improve the systolic blood pressure. So that's the first thing. Please let me go over it again. You look at it. This is cold. Perfusion problem is your first thing. Just by reading the question, you see the patient is cold. The first thing you want to give to the patient is the fluid. You now be like, if I give this patient fluid, it will worsen the wetness. So, no, I won't give fluid. So, you give the patient ionotropic agent. So, that's what you give to the patient. So, after you've taken care of the perfusion, you can now start addressing the wetness. So, what if you read the question, you realize that the patient does not have fluid in the lungs. It's just dry basically, and the patient is cold. So the patient is only having perfusion problem. So I will start with the fluid. So fluid. After that, I can go to ionotropic agent. if the patient is still hypoperfused. All right, treatment if not hypotensive. So the patient is not hypotensive. So this patient is only, what do you call it? The patient is only wet. So you just give the patient diuretics and vasodilator. However, this patient that is hypotensive, that is not hypotensive, and is wet, the systolic blood pressure is still low, but the patient is still having systolic blood pressure that is greater than 90. So just don't forget that you start with perfusion before going to wetness, and for the perfusion, the systolic blood pressure needs to be less than 90. And in the exam, just look at the systolic blood pressure, just look at them and dot it and be like, this is what I'm starting. So it's a logic of thinking that anyhow they give it, whether you've seen something related to it before or not, is none of your business. You just look at it and be like, the answer should be B. And you will come out of the exam and be happy that you picked something. Compared to, I saw something I can't pick because I've seen it somewhere before. This is about the acute congestive heart failure management. So the positioning is very important. Vasodilator, diuretic, and at least we've mentioned these guys here. Apart from upright positioning. Another one is if they are hypoxic, you can give them oxygen, which I believe everyone will do here. So there is something they also love to test in the exam, and that is this guy, non-invasive positive pressure ventilation. So this is another management you just want to note. I put something here, LMNOP. L is loop diuretic, M is modify the medication, N is nitrate and non-invasive positive pressure ventilation, O is oxygen if the patient is hypoxic, P is positioning with elevated upper body. So all what we've said is just what they put here. I put an arrow here because it has been tested before. Pharmacotherapy. These are the drugs you all know. There is nothing there. Loop diuretic. If I say we should list loop diuretic, everybody will list. We'll mention them. So we'll all mention them. Loop diuretics, furosemide, ethacrinic, bumetanide, torsemide. Amidst this guy, which of them is non-sulfonamide? Who wants to make a guess?
Ethacrinic.
Ethacrinic acid. All right. So please just let's watch out in case. The thiazide. So hydrochlorothiazide, chlorothiazide. I will show you how you treat hypertension. I know you know it, and I know majority of us here are authority in the field, but for the USMLE, I will still show you 1 or 2 points. So, and do not misinterpret our intent, as I used to say. We are not in any way saying that we are specialists in the field, but just for you to have an idea of ways of looking at things so that you don't end up overanalyzing the question and think that because the name is USMLE, it's one difficult thing they are asking. That's a lie. Most of the people that pass very well, they do not read that much. Once you start reading so much, you're thinking you'll be overthinking. So now let's look at these adverse effects in thiazide that you don't want to forget. You call it hyperglock. Just remember hyperglock. Hyperglock. Glock. GA is glycemia. What does that one mean? If the patient is diabetic, you need to be very careful of thiazide, because it may not really make the sugar to be that controlled very well. So you just want to be very careful. Then hyperlipidemia too. Thiazide. Hyperuricemia, thiazide. Hypercalcemia, thiazide. All right. What about the loop? Loop is hypocalcemia. Loop can also cause hyperuricemia. Loop can also cause gout. So, but the differentiating thing is ototoxicity and this hypocalcemia. These are the 2 points that you want to put at the back of your mind to differentiate loop from thiazide. Just these two, ototoxicity. So you might see the patient is placed on a particular antidiuretic, and the patient now start developing some hearing impairment, blah blah blah. And they just say, which one? Just go for loop. The patient is placed on a particular antidiuretic, and the patient, they notice that the lipid profile start becoming deranged, thiazide. Potassium sparing. These are the ones SEAT. We usually call them SEAT. SEAT. So SEAT. We have the one that are blocking the ENaC. So that's amilorate and trimethylene. These are the adverse effects anyways. Hyperkalemia, gynecomastia, sexual dysfunction, eplerenone. The difference between eplerenone and spironolactone is that spironolactone can cause gynecomastia. However, eplerenone does not cause that. So please just watch out in case they say the patient is complaining. What do you want to switch to? You switch to eplerenone. Carbonic anhydrase inhibitor, acetazolamide. You can't even go into the exam and forget acetazolamide. So Monte sickness, they use it. They use it in so many places. So here too. All right. The adverse effect is can be peg on solver, but they hardly test it here. So that's just by the way. Osmotic diuretic, that's mannitol and the likes. Okay. If the patient is having anuria, or you don't want to give it to the patient, or congestive heart failure, you don't want to give it to the patient because it's going to draw fluid into the blood vessel and worsen the intravascular volume for the patient. It's going to worsen. And don't forget that the kidney cannot eliminate fluid. So the heart will now become, heart failure that the patient is having will become worsened. Do you need to cram these jargons they put here? Sincerely speaking, you don't need to at all. So basically, look at the vasodilators. In the exam, if you look at what we said before, if the patient is wet, you want to place the patient on diuretic and vasodilator. You are like, diuretic, vasodilator, diuretic, vasodilator, diuretic. Which vasodilator will you now give? Option A, nitroglycerin. Option B, nitroprusside. Option C, they just list them. You know, say, in the first stage, I saw nitroglycerin, I saw nitroprusside. The two of them are there. Which one do I pick now? That's why you need to rehearse it. If the patient that is having this heart failure is also having hypertension, nitroprusside. If this patient that is having this heart failure that is wet, is not having hypertension, nitroglycerin. Can you see the way you separate them? So all you need to rehearse, check, remind yourself is there hypertension? Is it not? If it's there, nitroprusside. If it's not there, nitroglycerin as the vasodilator. What about the inotropic agent? If the patient is having perfusion problem, and don't forget, the patient is wet, the patient is also cold. We say there is fluid overload, there is also poor perfusion. And I checked for the systolic blood pressure, and I realized that it's less than 90. I'm like, I need to quickly tackle this perfusion. So because it's wet, I can't give fluid. I need to just go straight to inotropic agent. Which one do I want to give? Milrinone, dobutamine, dopamine, any of them. Now relax. In the exam, they will give option A, milrinone. Option B, non-epinephrine. Option C, dopamine. Option D, vasopressin. Where will I start from? You actually start from this inotropic one before you go for vasopressor. You don't go for vasopressor before going to inotropic agent. That's why you need to know the order. Or else, in the exam, you may be confused. All right. So these are the other treatments. So this, can you see, there is nothing to cram here. Nothing to actually, you just need to look at it and revise it. Dr. Mawumi.
Yes, sorry, sir. Please, can you go right again? Which one is first? Which one is second?
So inotropic agent. So look at it here now. They just say, you look at the question, the patient. Okay, this is wet. Dr. Mawumi, how do you know it's wet from the question?
They will have respiratory
distress
issue.
or crackles and the likes.
Yes.
Okay, so you already know it's wet. You now check the question. They say they touch the patient, it's cold and the likes. So there is wetness. There is also poor perfusion. Which one do you want to address first, Dr. Mawumi?
The perfusion first.
Perfusion. So you want to address the perfusion. So what do you want to use to address the perfusion that you are thinking about? The first line. Fluid, Abby. You say fluid. You
Fluid.
wanted to say fluid?
Yes, fluid.
Yeah, you are thinking towards fluid. Just fluid. The second one should be ionotropic
Ionotropic agents,
exactly. But you can start with fluid here because there is wetness.
Wetness, okay.
So we now say we just focus on ionotropic agents. It's actually when you've given ionotropic agent and you want to go further that you'll be thinking towards something like vasopressor.
Okay.
So that's that. Call me. So I need to bring it out for you. So inotropic agents are used initially. So that's just what you focus on first, basically. All right, I think that's just that. Do you get it now, Dr. Mobumi?
Yes, I get it. Thank you very much.
Right, that's fine. Okay, so that's just that about this. So if you look at it, you don't cram this because you can't go and be shouting oxygen and loop diuretic. It depends on the condition that they are giving. Is it wet or cold? All right, then we come here. There is nothing you are expecting them to be testing here. Chronic heart failure, and I've already mentioned something about chronic heart failure. So most time, people that have acute heart failure that you've treated, they come to the hospital. They bring them to the hospital. You're like, doctor, save us. You look at the acute heart failure, you treat them basically depending on whether it's wet or cold. So you've already sorted the patient out. The patient is now going home. Thank you. The patient is not. Your treatment does not label the patient as heart failure patient. However, the patient is no longer in acute heart failure. So most of the time, the patient is just in a chronic heart failure. All right. So now they are better, but they are not cured. So what do I want to give to the patient? The drug you want to give is, Baba, as you are going home, so that you don't go out and pie, we shall need to place you on drugs that will reduce mortality in them. So if it's drug that will reduce mortality, basically, you'll be thinking towards something like these guys, beta blocker. Remember the drug that will block the SNS and also block the RAS. So these are the drugs you focus on. So they reduce mortality and morbidity in the patient. Ivabradine too can also be given. You usually give this. So this is actually your first, this is where you are expecting them. This is your first thinking. Drug that will block this. Just this. Do not go into the exam and be shouting, I saw ivabradine in the first aid. Now I'm now picking it because you saw it. That's wrong. This is all you're thinking. All SNS, drug that is blocking the SNS, also blocking the RAS. Drug blocking the SNS, blocking the RAS, blocking the SNS, blocking the RAS. You only think about these other guys, most especially this ivabradine, if the pulse rate is high. The pulse rate is high despite the maximum tolerable dose for beta blocker. The pulse rate is still high, greater than 70. That's when you now say, what do you want to add to it? Ivabradine. It block the phonic current. Ivabradine, phonic current. There's someone we call Ifa in Nigeria. Ifa. Once a minister of health, anyways. All right. So that's just by the way. Just note it. Then ivabradine. All right. Low dose spironolactone too is also going to reduce mortality. This is also going to affect the RAS. The next one that you need to focus on is this dapagliflozin or empagliflozin in the exam. Dapagliflozin. These are actually new generation drugs, like these guys. You can go and say you forget it. They are very awesome, like very, very awesome. So they are sodium glucose transporter 2 inhibitor. So you can use it in a patient that's having reduced ejection fraction and also preserved ejection fraction. So now you go for this in your option if the patient is also having diabetics, because this will throw glucose out of the urine. It's going to throw it out through the urine, and it's also going to reduce mortality in the patient. So it's more or less like you want to use one stone to kill two birds. So it shows that the patient has been on beta blocker or something, and ask which one do you want to add to it. And this diabetic patient, let me say you are using ACE high rather. So you are using ACE high. You don't want to go for beta blocker. You go for ACE high. Don't forget diabetic patient having heart failure and the like. So you go for ACE high. All right. Immediately you see ACE high. What else do you want to add to it? It not be the dapagliflozin or empagliflozin. So there is nothing concern you about this guy. So this is where your thinking starts from for chronic. This is where all your thinking will start from in the exam. This one. So you can't just be jumping here and there and be shouting a low dose. Your thinking start from here. So if I thought you now want to add anything to it, now be amidst the others. Alright, so that's for this. Hydralazine isosorbide dinitrate can reduce mortality, morbidity. So loop diuretic, digoxin, these are the other. You don't need to cram them. Don't bother. You go for acetylsalicylic acid aspirin and statin. You add it to whatsoever you might have given to the patient here. If there is if the underlying cause is prior MI, if the underlying cause is a prior MI, you add this one to it. All right. So if the patient is having diabetics, you add this one to it. If there is nothing else they are giving, just stay here, and this one you really has. All right, and that's that. So you can read what they put here. It's the same thing you have noted. So loop diuretic will lose calcium, so it will cause hypo. Is the one that have letter O in it. Hypocalcemia. Thiazide we take it is going to cause thiazide, hypercalcemia. So both of them will cause hypokalemia and hyperuricemia. So both of them can cause gout. Device therapy. Nothing much about it, but you just want to pick, just for you to note one or two things. So intracardial device, ICD, is just indicated if the patient is symptomatic with ejection fraction less than 35, or asymptomatic with ejection fraction less than 30. So just for you to realize, but you are not expecting much from them. If I thought you solve any question anywhere, so you are not expecting them to, because in the emergency, this is not what you are thinking about when the patient comes. So these are more of specialty treatment, device therapy. So you can think about it and predict how they will test, because they only text basic knowledge that they want everyone to have while they are resuming their residency. The rest, they will build there. So if you now go and start from the top, so you are just jumping the case. So just relax and pick simple stuff, or else you will just be having headache. All right, so that's just by the way. Digoxin. Digoxin is a drug everybody knows, so it can actually increase the contractility too. So now you just want to understand the way digoxin toxicity is going to look in the exam. So how will they, they will have portrayed the patient is now on a particular drug, blah blah blah, and the likes. So the way the patient will present with something related to cardiac, GI, and also neurologic. So with respect to the cardiac, you'll be seeing something like atrial tachycardia with AV block. Atrial tachycardia with AV block. Atrial tachycardia with AV block in the exam. Digoxin toxicity. Atrial tachycardia with AV block in the exam. Digoxin toxicity. This is what you are thinking about. These are the other drugs that can actually precipitate the digoxin toxicity. AB, amiodarone, beta blocker, calcium channel blocker, the non-dihydropyridine calcium channel, the macrolide, amphotericin B. So these are the other drugs. They can precipitate it. So a patient that is taking digoxin, also taking verapamil, or taking macrolide, or using one antibiotics, maybe azithromycin or erythromycin or something. So you now start seeing the patient is having diarrhea, the patient is having atrial tachycardia with AV block. Just know you are most likely dealing with digoxin toxicity. Alright, so you might review the medication. So how will the ECG look like? So you can see the ECG. This is the ECG. So you see a lot of P wave, P wave, P wave, P wave, P wave. you now see one KRS complex. So can you see? So there is more or less like a block. So the thing is not really being transmitted. So that's why they talk about atrial tachycardia with heavy block. All right, that's what you are seeing. Atria. One of them will now go for the ventricular. So that's why you are seeing 5:1 block. All right. This is another thing you can see. The Digoxin effect refer to normal ECG changes in patient taking the Digoxin. So downsloping ST elevation, depression that look like a reverse stick. All right, but just note this one very well. So that's just, by the way, just for you to have an idea about the other adverse effects. So you can see cardiac, nausea, vomiting, anorexia, abdominal pain. You can also be having diarrhea. Neurology, they may be confused, weakness, color vision. So that's another thing they can also have. What about the heart failure with preserved ejection fraction? So this one, when you read the question, you will just see symptoms and signs of heart failure. You will now check the question. Ejection fraction they will give you will be at least 50%. Once you see that, you'll be like, this is actually heart failure with preserved ejection fraction. So don't forget, symptoms and signs of heart failure will be in the question. Ejection fraction will also be given, and you will see it's going to be at least 50%. That's when you'll be thinking towards heart failure with preserved ejection fraction. Now, what are the causes? You already know that the ventricle has impaired active relaxation, is not relaxing, and the kind of heart sound you will be picking here will be the what? Which heart sound will you be picking here? Anyone? S what? S4.
Yes.
S4, exactly. So
Yes,
yeah,
S4.
you'll be picking S4 here. All right, so that's what you'll be picking here. So all this hypertrophic cardiomyopathy will cause this, restrictive cardiomyopathy will cause it, whereas dilated cardiomyopathy will be related to heart failure with reduced ejection fraction. So now, how do you want to diagnose it? Echo again. Echo. Yes, echo. Then the laboratory brain natriuretic peptide is also going to be elevated. Heart failure is heart failure. So the same thing for what we looked at before, the same thing is here. So the same thing. The only difference you are seeing here is ejection fraction, just differentiating them. Or on the examination, they may say that the heart is normal. Like when in the examination they are picking for the cardiac examination, the apex of the heart is at the normal position. So what about the treatment? The treatment is diuretic. Diuretic will help. That's the best initial. So just diuretic. What about any drug you can give that will reduce mortality in this patient? The only drug they will test, they've been testing, they have tested, they will test tomorrow for those that will write their exam tomorrow, is still going to be this empagliflozin or dapagliflozin. That is the only drug that reduces mortality in them. So when you read that question, you just realize that this is heart failure with preserved ejection fraction. Now, which of the following is going to reduce mortality in this patient? A, empagliflozin. B, ACE high. C, beta blocker. D, ARB. Or just listing all of them. So the answer is this. Empagliflozin is the only drug to reduce mortality. Whereas for systolic heart failure with reduced ejection fraction, you have so many drugs you can be playing around. This is the one they've been testing. They will test it. So please never forget it at all. All right. So if at all you are dealing with any other comorbidity, you can be thinking about the other drugs and the likes. Beta blocker is the first line. Then ACE, ARB, and the like. But never forget these guys. Empagliflozin, dapagliflozin. All right. And that is actually the heart failure. All right. Let me take us through cardiomyopathy. Are you awake?
sir.
Very awake.
Okay, so let's be awake. So just get the gist. If you look at it, we are just gisting. Yeah, just there is no stuff here. If you look, I don't move stuff. I don't know stuff, but just gist around it and be like, what we they has here? What we they has here? Take them into the exam and you realize that your head is light. You are not overthinking and you are not afraid because the little you gather when you are jittering, majority of them will now start escaping. You start escaping. So in fact, when you enter into the examination area and someone is like, do you know this? Do you know this? What of this question? Just say they are not going to ask me. They won't ask me. They won't ask me. Any difficult question you see anywhere, just say they won't ask you. But some people, instead of them to say they won't ask them, they say they may ask me. How come is that one they will not ask you? The simple one, they will leave them. Confess positive things. And that's it. That's it. They won't ask me that question. It's not going to come out for you. Cardiomyopathy. How do you want to be looking at cardiomyopathy? This is basically also heart failure. However, the cause of the heart failure is something related to the muscle of the heart. So cardiomyopathy is just have this myocardial disease. So the symptoms and signs may actually look the same. Now, you have the dilated, you have the hypertrophy, you have the restrictive cardiomyopathy. Look at the dilated. So what you see here is impaired contractility, so it will balloon out. Definitely you will see the heart will be big. So that's for the dilated. So you are not surprised. All these left ventricular cavity increasing in size, left ventricular cavity size high, ejection fraction is reduced, you agree with them. Then thickness is reduced. So when you now check the question, you realize that the left cavity size is actually reduced, it's not increased. It's either you are dealing with hypertrophic or restrictive. Can you see? Hypertrophic or restrictive. Hypertrophic is due to impaired relaxation, then restrictive is due to impaired elasticity. So when you say something is highly elastic, like the lungs, they are highly elastic and the like. So when you just say something is highly elastic, what it means is that it can return to its original shape and size after the deforming force has been removed. So that's elastic. So when there is impaired elasticity, the impairment in elasticity, just know that the heart, when blood is entering into it, is not something is deposited in the muscle of the heart that's reducing the elasticity the way it should be. All right, that's just by the way. So you see something similar to the hypertrophy. So don't give yourself a headache. They just look alike. So even ejection fraction too, wall thickness usually increase. This one is also increased. Ejection fraction is normal for the restrictive. It can be increased or normal in the hypertrophy. So reduce. So you might not really be able to differentiate them, but there will be some clinchers, and I will show you. So let me show you. So if you look at the wall here, basically you can see it's thick. Look at the cavity size is reduced. Cavity size is in, just is dilated. This is hypertrophy cardiomyopathy, or we may even be dealing with restrictive cardiomyopathy. So let's look at the dilated. If it's dilated now, it's looking more like systolic dysfunction, so S3 heart sound. So what are the causes? I want you to look at the peculiarity with which we will look at them, so that in the exam you can close your eyes and predict the one you are dealing with. So definitely the left ventricular cavity size will increase, ejection fraction will reduce, all those stuff. What are now the causes? Idiopathic or genetics, they don't know what is causing it. There might be some genetic attributes. Then secondary causes, they are this. Most of the questions will revolve around the secondary causes. United States is a place where people drink a lot of alcohol. So alcohol. You don't joke with it. So alcohol-induced cardiomyopathy, dilated. So for all you care, that might just be what we are dealing with. All right, 1 minute, please. All right, So alcohol, don't forget alcohol. The next one they love to test is post-viral myocarditis. Relax, let me show you how it will come. You will now read that question. Young lady, young female, maybe 30 something years old, now having something that's looking more like heart failures, this thing. Just this picture. Left ventricular, this one, that one. You're like, what is causing it? They will now tell you. It's either they mention something that would tell you, draw you closer to post-viral, or they say that, or they never mention anything. Why? If I asked you 2 weeks ago, did you have any viral infection? Everybody here will say no. Even when we have. So the patient might not even remember that she had. And that is what is causing it. So when you look at the question, it's most likely going to be void. You can't see any clincher there. And the patient is young. What is now causing your cardiomyopathy? Most likely is post-viral. Do you take alcohol? You say, no, God forbid. Do you take this? No. Maybe you are just dealing with post-viral. So that's that. Then postpartum, we'll look at postpartum separately. We'll look at these drugs, radiation, and the like. So Chagas disease, these ones, they've tested them before: alcohol, post-viral, Chagas, nutritional disorder. So just rehearse them very well. You also have Coxsackie HIV. Just rehearse them. So it can be, for all you care, the question might just be related to alcohol alone. I miss them. Or they may not even ask it at all. So an S3 gallop signifies rapid ventricular filling. They will ask you this because it's a fact from from step 1. S3 gallop is showing that there is a rapid ventricular filling. All right. Can you see? Look at the examination finding. Displacement of the left ventricular impulse because it's dilated. So jugular venous distension, rail, S3. Don't mind this S3/S4 unless the heart is, maybe you are also dealing with restrictive or you are also dealing with hypertrophy. So, but S3, you just focus on this. All right. Dr. Ekweme. You wanted to
Okay, in that, yes, no, I just wanted to, I remember something that was viral. I've seen a question like that. What the point idea was the code that the patient had code 2 weeks ago.
Exactly. So that's how it's going to come. You just say one, either you see, maybe I forgot to also mention it. So you just see maybe 2 weeks ago, the patient had the flu-like symptoms. So once you see that, and now the patient is, so, or the question is just void. You don't see anything. So you just start thinking towards, I hope this is not secondary to post-viral myocarditis. And it's very easy, no headache, or you are just the one thinking, because you are the one that want to cram the whole stuff. You don't need to. Just pick what you can pick and forget the rest. You cannot, don't try to play to be an hero now. You are still going to win that Nobel Prize in cardiology. You are still going to, but just look at things simply so that you won't confuse the people around you that the exam is difficult, or because you are reading for 27 hours in a day. No, now. So just look at the revise within some hours, you are okay. What about the S4? Gallop signifies the stiff, non-compliant ventricles. So they have tested it before. They just say what is causing the S4 sound, what is causing the S3 sound. S3 is rapid ventricular filling. S4 is the stiffness of the ventricle. Shikena, that's all. So how do you now want to make the diagnosis of dilated? Echo again. So what about the treatment? The treatment just address whatsoever you see in the question that is causing it. So if the patient is taking alcohol, you just say, counsel the patient to limit alcohol. If the patient has been maybe having any condition you can see there, maybe endocrine disorder, just address whatsoever you can see there. So, and that's all. So what about the hypertrophic cardiomyopathy now? So now you need to be very careful here because of the way they think here. So please be very careful. Hypertrophic cardiomyopathy, so genetic too. Then the problem they have is there's tonic dysfunction. They can't really relax. The heart cannot relax. That's what I mean. And when you look at the wall, it will be thick. So basically, and if at all there is asymmetric hypertrophy of the interventricular septum, the patient will develop what you call hokum. So look at the interventricular septum is very thick compared to the other part of the body, other part of the ventricles. So the patient will develop hokum, hypertrophic obstructive cardiomyopathy. All right. So there is a way the patient is most likely going to present, either with sudden cardiac death or someone that is just having arrhythmia following exercise. All right, so that's basically stuff. So the other causes of left ventricular hypertrophy you may want to note: hypertension. This is the most common cause. So the rest here, you may just look at them and be like, I've seen them, but this is the one you want to focus on again. Hypertension again, hypertension. This is the most common cause. So most of the time, if I thought they would test this, they would rather test their hypertension than to be dancing around this fibrin, amyloid, sarcoid. They don't have those time. So hypertrophic obstructive cardiomyopathy is the most common cause of sudden death in young LD athletes in the United States. Now ask yourself, where am I going to? Is it United States? Then you need to note the hokum. You need to note it, because it says the most common death of sudden, the most common cause of sudden death in young healthy athletes in the United States. So it shows that you can't claim that I forgot to revise it. It's a lie, because they want to integrate you into their society. So what about the history? How will they present syncope or sudden cardiac death in a young healthy athlete? Just say hokum, or hypertrophic cardiomyopathy. So what is going to be the key finding? All those maneuvers we were talking about before, they are the one you will see here, key findings when they are examining the patient. So anytime the preload is increasing, the intensity of the murmur will reduce, all those kind of stuff. That's what you will see here. So if I thought the patient is doing exercise, using diuretics, the symptom will worsen. Why? With dehydration, diuretic, exercise, the preload will fall. Basically, most especially if the patient has actually is already dehydrated. First of all, remove this exercise. So the preload is going to fall. So when the preload falls, the intensity of the murmur will increase. The obstruction will become more magnified, and the patient will have more symptoms. So basically, all right, this exercise worsening is actually because of contractility that is actually increasing with exercise. So when you do the exam, what will you be seeing? S4, just hypertrophic S4. What about the diagnosis? The best initial test again, echo. We now get there, you are seeing ECG. Have we mentioned ECG since we started here? Echo. So, echo. What will you see? Asymmetrically hypertrophied interventricular septum. That's for hokum. They can also have dynamic obstruction of blood flow in hokum too. So, then you can now be thinking towards ECG, but you don't need that. So, the next thing they may want to test is chest X-ray. When you do chest X-ray in them, you will see left atrial enlargement. Now, if at all someone tells you, Dr. Omowumi, you are going into the exam, hypertrophic cardiomyopathy, what don't you want to forget? This is one of the things you must never forget. Left atrial enlargement. You will say, that guy mentioned it. Left atrial enlargement. Why? Because when they give you the question will look like something. And that thing is what we call athlete heart. And first aid comes here and tells you key facts, athlete heart. What does this mean? In the exam, you have two battles. Hypertrophic cardiomyopathy or athlete heart. You are not sure, is this an athlete heart or this patient is having hypertrophic cardiomyopathy? Look at the left atrium. If the question says there is left atrial enlargement hypertrophic cardiomyopathy most likely. If the left atrium is actually normal in size, you are most likely dealing with athlete heart. Left atrial enlargement? Maybe I'm dealing with hypertrophic cardiomyopathy. Left atrium, normal left atrial size or something like that. You are most likely dealing with athlete heart. Maybe the person is an athlete. That's what it means. Left atrium, left atrium, left atrium. So you cannot come here and say, yeah, I saw the left atrium. I just thought it's just a normal note. Nope, it's not. It's what you are going to, it's one of the few points you will use to tear athlete heart away from hypertrophic cardiomyopathy. Just look at it. Because there are so many points, you can't focus on many of them. Other stuff is positive family history. So you receive positive family history or something like maybe sudden cardiac death and the likes in patient with ACM, ECG changes, you will see it. The echocardiography features you will see, can you see? Then left ventricular thickness here is greater than 15. In athlete heart, it's actually going to be less than 15 millimeter. So you just get there, you've even forgotten, but you remember that day when I was talking and shouting, left and note the left atrium, left atrium, left atrium, left atrium, left atrium. If it's enlarged, hypertrophic cardiomyopathy. If it's normal, athlete heart, note it. That is it. So when they give you in the exam, you'll be like, okay, this is what they are trying to test here. All right, so that's just by the way. So left atrial size here is normal. This one is enlarged. So left wall thickness is 15 and above. Athlete heart is less. So you may not remember much, but don't forget these two. Left atrial size. This left ventricular wall thickness. So hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy. What is going to be you've already done echo, you've done this, you've done that. What is the best initial treatment? The best initial treatment here is beta blocker. Beta blocker. Never forget it. The best initial treatment for dilated cardiomyopathy, address whatsoever that is causing it is the answer. Don't go and be looking for one big drug. The best next step is address it whatsoever that is causing it. It's likely to reverse back. If it's one endocrine problem, address it is likely to reverse back unless the patient is in failure. That you just need to treat the heart failure. But here, beta blocker, they are at risk of arrhythmia that can kill them. Leader arrhythmia that can kill them. Beta blocker are the best initial therapy for symptomatic relief in ACM or HOCM. If you check the options, you don't see beta blocker. What are the other drugs you use to replace beta blocker if you don't have it? Non-direpiridine calcium channel blocker. So never forget this. And ventricular pacemaker, both of them are second line agents. The first line is beta blocker. So they give you the hypertrophic cardiomyopathy. You're like, hypertrophic. Now see, what do you want to give to this option? A, beta blocker. Option B, ferrapamine. Option C, this. Just list them. You're like, you can use this. You can use all of them for this patient. No. Yes, you are right. You can use them. But don't forget the order. This is the answer. Beta blocker. Beta blocker. Beta blocker. Beta blocker. Beta blocker. So all the rest they put here, you don't bother yourself. This is just what they will test. For people with HOCM that's symptomatic, you want to give them implantable defibrillator because they are at risk of leader arrhythmia. So don't forget that. All right. So that's just by the way. There's another fact for the exam. Infant that is born to mother with diabetes, they are at risk of two things. We remember them that are related to the heart. The first one that you read in step 1. Who remembers that condition? TGA, transposition of great artery. So now, transposition of great artery. So that's the second one is ACM. Can you see? ACM. Why? You know, people that are diabetics, basic. I mean, mothers that are diabetic, you like, go and meet them, because your baby will be very big. Your baby will be very big. The way you are saying it, the same way the heart will also be very big. The heart also can be very big. So hypertrophic cardiomyopathy. But now you see the baby is born at TGA and TGA and hypertrophic cardiomyopathy. So the baby is big. They now bring the baby. They say that this is a child that is born by diabetic mother, blah blah blah. And you look at it, you're like, oh, this is hypertrophic cardiomyopathy. That's what you want to do. Best next step. Nothing. Reassure. Most especially if the patient, the infant or the baby is actually asymptomatic. You just reassure them because it's going to get better. You don't need to be doing one heroic unless the baby is symptomatic. So if the baby is now symptomatic, what do you want to give again? Fluid and beta blocker. Beta blocker, beta blocker, beta blocker, beta blocker, beta blocker. That's what you are looking for in the question, not any other thing. Any other stuff, just put them aside. All right, so that's just by the way. Arrhythmogenic right ventricular dysplasia. Arrhythmogenic right ventricular. So what is it all about? And all the points you are looking for in Sokoto is already in the pocket of your first aid. I feel first aid is actually underrated. Possibly maybe the way they wrote the book is basically a book for USMLE. You don't have any other unnecessary stuff in it. So you can be sure that whatsoever you are reading, it only has minimal or low volume of distractions. So you just look at it and be like, what do I want to pick here? So you can read your first day back to back, read it again back to back, read it back to back, and go into the exam with the whole point. So you will know that you are cardiology ready. So what do you have here? Arrhythmogenic right ventricular dysplasia. That's the name. ARVD. It's a genetic disease with autosomal dominant inheritance. What you have is myocytes are now replaced with fibrofatty tissue. So they will put this in question on biopsy. They notice that the fibroblasts are replaced with fibrofatty tissue. What's the diagnosis? Arrhythmogenic right ventricular dysplasia. This is it. So this will cause right ventricular dilation. Then if anytime any chamber is dilated, the possibility of that chamber developing arrhythmia is very high. That's the same thing that happens in mitral stenosis, that you are seeing atrial fibrillation emerging when the left atrium is dilated. So they asked this recently. So it is the second most common cause of sudden cardiac death in young people. So it can be tested. So please just watch out for it. After Okum, what is going to be the presentation? Palpitation that is due to ventricular arrhythmia. Palpitation. So they won't put you in the dark. They don't do that. They will just say the patient, and they did biopsy. They now notice a lot of fibrofatty tissue within the heart. What's the diagnosis? Arrhythmogenic right ventricular dysplasia. So this is the diagnosis: echo, the histology with biopsy, endocardial biopsy, ECG. This is what you see on ECG. So you can see this epsilon wave here. This is just the way the ECG will look like. So if they give you something like this, that's fine. If they don't give you, if it makes sense to you, fine. If it doesn't make sense, just throw it aside. You are not bothered. Just move away. So how do you want to treat it? Just avoid avoid physical activity, because during physical activity is when they die. They usually develop the arrhythmia, then they now die. All right, so if at all you want to prevent the sudden cardiac death, you can give them intracardiac device, so that anytime they develop arrhythmia, the thing will suppress it. So you can also suppress the arrhythmia with this beta blocker. So just beta blocker feels the first line. Just note it and move out, and that's okay. The other stuff, you can just look at them and be, I've seen you, because you won't remember all of them. Just limit them to 1 or 2 points and move out. Most of the time is the first line they test. If at all they want to move occasionally, maybe 1 or 2 questions, you can even count the total number of questions where they will be testing the second line. It's not common, it's just the first line, just to put everybody on the same spot. Beta blocker. So you can look at it like ACM, they look alike. avoid physical activity, then beta blocker. All right, so that's just by the way. Restrictive cardiomyopathy. How does this look like? So restrictive, you already know that there is impaired elasticity. So you have decreased elasticity of the myocardium, which will lead to impaired diastolic filling. So it's no more elastic. All right, so now what will they be asking in the exam? The first question is about cardiac amyloidosis. You are like, wait, what be this? Relax. Very easy to identify. Very, very easy. All you will see in the question for the cardiac amyloidosis is actually a patient that is having heart failure. You will now see something related to kidney most of the time. If it's not kidney, tongue. This is what you will see. You just see heart failure. They will not say on examination, they notice the tongue of the patient is very big. The patient has macroglossia. Just drop any other thing you are reading there. Go for cardiac amyloid. That's the answer. You will always see, there will always be a clean chart that will draw you towards this cardiac amyloidosis. Either macroglossia, proteinuria, easy bruising, hepatomegaly. Now, your friend is going for exam. Two of you are going for exam next week. You now be like, let's revise this restrictive, this thing and the likes. You're now like, okay, how will you know that this is actually cardiac amyloidosis in the exam? You just say that. You are expecting the person to say, you are most likely going to see a question related to heart failure, and they may put either easy bruising, proteinuria, macroglossia, or hepatomegaly. And that's all. The others are story. Best initial test. Best next step. Echo. Most accurate test to confirm the diagnosis. Tissue biopsy. What about what is left in between? Ignore. Just this 1, 2, 1, 2, 1, 2, 1, 2. Not to sit down and crown. Is it there? Is it this? Is it that? Who cares? Make it light for yourself. It doesn't need to answer all the questions you have in your question banks that flying around. Because most of those questions, you won't even remember them. You might have even forgotten that you solved them. But if you solve them a couple of times, you have the answers at the tip of your fingers. It doesn't mean you know them. So you only have the answers. That when you see the question, you're like, I know the answer is B. Sometimes when we project question like that, the answer is B. They've not even read the question, they are shouting, B, B, B. I'm like, let's even read the question first now. But this will give you an idea that anyhow the question comes, whether it looks like what you've seen before or not, if I'm going to go for cardiac amyloidosis, I have something to look for in the question. All right, so that's just by the way here. The treatment, diuretics, that's the main treatment. So AC high, beta blocker, they are not beneficial. Treatment of bradyarrhythmia with pacemaker. So that's just this about the cardiac amyloidosis. What about the cardiac hemochromatosis? You is here that will say, I don't know hemochromatosis. Yes. Everybody here has an idea about hemochromatosis. So all you will see is that this patient is having symptoms and signs of hemochromatosis, which may be related to the liver, it may be related to the knee joint, it may be related to all those stuff. So you just know that this is looking more like hemochromatosis. It may even be related to the skin. It may be related to the pancreas. You just see all those stuff there. You now see the patient is having symptoms and signs of heart failure. You're like, heart failure, joint problem, liver derangement, liver enzyme derangement. You are seeing all those stuff. And they even mentioned something that look like brown skin. You are like, I hope this is not a hemochromatosis. That's that. So that heart failure will now be cardiac hemochromatosis. So the next thing is, what is the best next step? Don't forget that they've not even investigated. Just see that this patient is having heart failure, having all manner of stuffs that are occurring together. So if the prominent symptom there is actually about the cardiac hemochromatosis. The thing you want to check for should actually be what's going to help you to establish the diagnosis echo. But the first thing you do is iron study. Now relax. If you look at it, the first ADL put iron overload, you want to first of all establish it, because you are only seeing that this patient is having chest pain, the range liver enzyme, diabetes, is also having heart. You're like, how this is not hemochromatosis. Quickly, your best next step is iron study. That's the answer. Iron study, because you want to first of all know what is this patient having. Ganga, is there iron? Transferrin is high, ferritin high, serum iron high, liver dysfunction, ALT high, this one high. Iron study. What do you want to use to confirm the diagnosis? Genetic testing. To now narrow it down to the heart, echo. So at least you start from iron study. All right, so that's that. Iron study, genetic, just rehearse it, like let it flow. Rehearse it. But if you come here, you want to cram everything here. No, we've had you. So what about the cardiac sarcoidosis? Cardiac sarcoidosis. All you will see is heart failure. That heart failure, they will now add something to it that is related to sarcoidosis. It shows that heart failure is from sarcoidosis. What are those things they will add? The clinchers they are most likely going to put. Number one, uveitis. Uveitis. Blah, 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 blah. Erythema nodosum. Erythema nodosum. So see it, because they may just show it in the picture. The heart failure is there. Can you see the erythema nodosum? It just shows something like this. And someone will now come out of the exam and is shouting, they gave me a lesion on the skin. I even thought it's AWO. I thought it's pimples. I thought it's okay, we've had you. Sarcoidosis. All right. So can you see something? Just give one anyhow. Okay, these are erythema nodosum. Can you see them? They will just put them there. So when you see them, you'll be like, or uveitis. I just show the eyes like this. And just show the eye like this. So can you see? Can you see all this area? So this limbo cornea junction area here. Can you see? Can you see? Can you see? Can you see? So just see something like that. So if that's all they just give you, just know that this most likely with cardiac sarcoidosis. Heart failure, heart failure, heart failure, heart failure, heart failure. So the most likely arrhythmia they have is AV block. AV block. All right. So another thing they may have is lymph node, lymphadenopathy. You just see heart failure. Now see a lot of lymph node, just say sarcoidosis. Or heart failure with hypercalcemia, you just say sarcoidosis, cardiac sarcoidosis, and that's all. All right. What about the endocrine? So this is actually the endocrine. You have the acromegalic cardiomyopathy, diabetic cardiomyopathy. Definitely, you will see something related to growth hormone here. Enlarged hand, enlarged feet, enlarged face, and the patient is having heart failure. Acromegalic cardiomyopathy. All right, so never forget that. So that's basically that. Diabetes, you will see the diabetes in the question. So these are the drugs. Shit. You go into the exam. You now say out of everything you want to forget is that these drugs, you don't like drugs. I don't like drugs. Don't joke with it. No, don't do that. That would be wrong. The drugs may be, most of the time they are chemotherapy related. So you call it chemotherapy related cardiomyopathy. One of them is anthracycline. This is the most common one. You just check the question, just the anthracycline. So they may give you doxorubicin, anyone. So and all those rubicin rubbish. So if not that, they can give you cyclophosphamide, they can give you trastuzumab. So now this trastuzumab has been tested before. You see this one, anthracycline, has been tested before. So I still, all right, so please never forget, you just see they will mention them: anthracycline, then trastuzumab, then cyclophosphamide. So they will ask them, they will test them. Like as I'm mentioning them now, the way the thing will play out is that when some of you get into the exam, you will hear this voice again and be like, I remember when we were doing that webinar that guy was mentioning it, that he mentioned this. They gave me question on it. Because these are the common things that occur commonly. All right, so, and that's just by the way, that's that. Okay, so I will just leave this. All right, ECG frequently will show left bundle branch. I've mentioned something about the left bundle branch block before, so in relation to MI, so do not forget that. So that's just by the way, so nothing really to pick here. What about the secondary cardiomyopathy? Secondary cardiomyopathy, we've already looked at the majority of them. So 50 to 70% of patients with AL amyloidosis have cardiac involvement, and this is actually the main prognostic determinant. So as I mentioned, amyloidosis, I'm very sure majority of you are already thinking how the question will come. You're already thinking how the question will come, that okay, they are most likely going to just give me a patient with this, maybe renal involvement, macroglossia, this, that, and the likes. All right, so that's just by the way, and this is the main prognostic determinant. Never forget, is the main prognostic determinant. So when you read the question and they say, what's the prognostic determinant in this question? It's actually that AL amyloidosis. Now, these are the other conditions we want to look at. USMLE will not joke with them. Myocarditis, we've looked at myocarditis briefly the other time. Now, what is the cause? The commonest cause here is actually the Coxsackie B virus. Your friend is going for exam and is like, myocarditis, I hate it. But you should still take 2 or 3. Let me leave you with 3 or 4 points to take into the exam for the myocarditis. The commonest cause of it, Coxsackie B virus. It's actually the most common cause of the viral myocarditis, definitely. And the viral is even the commonest amongst them too. So Coxsackie B virus. You can say it anytime you like. And miss all the virus is the one. If they do not test it as Coxsackie B virus, they will test it as picoRNA or piconavirus. So the answer, okay, this is most likely, or each of the following is the most likely cause of the maybe myocarditis in this patient. The answer will be A, piconavirus, B, shall put all manner of stuff. The answer will be piconavirus. If not that, Coxsackie B virus. All right, and don't forget the way the question will come. You will definitely see something related to flu-like symptoms in the question. Maybe like 2 weeks ago or something, the patient now develops something that is related to heart failure. You just be like, this is myocarditis, until proven otherwise. All right, so how do you want to diagnose? It's clinical. From the story now, you're already shouting myocarditis. So you can also see some inflammatory markers, echo, and the lab is clinical. So what is the most accurate test? They'll now say, what they will ask is that, what do you want to use to confirm the diagnosis? So, which is rarely done. It's actually the biopsy. So most of the time, you just need to diagnose it. Coxsackie B virus, and the question just revolves around this area, basically. Peripartum. Chai. No, it's not allowed. No, you can't do that. You go and forget peripartum. With the way Africans don't do family planning, they go there and they start peripartum. It's not allowed. You can't say you don't know. No one will forgive you even if you forgive yourself. Peripartum. What will happen here? Definitely this will be related to pregnancy. Definitely it will be related to pregnancy, and the pregnancy is going to be related to I want you to look at what I put arrows on here. Some arrows are thin. Some arrows are moderate in size. One of them is moderate in size. One is very thick. That's just to show the categories of questions you are expecting. So you will see this patient, this question is related to pregnancy, and usually towards the what do we call late phase of the pregnancy, or the first 5 months of delivery. So the patient can have dyspnea or topnia, paroxysmal, just something related to heart failure. But when you check the question, you're like, this is a pregnant woman. Oh, this woman just delivered. Pregnant woman, just deliver. Pregnant woman, just deliver. So likely you are dealing with peripartum cardiomyopathy. So if that is the case, what do you want to take into the exam? All right, best next step, no matter how they portray it, echo. Best next step. It is that echo you will use to look at the left ventricular ejection fraction, and that is where all your thinking or your analysis must be. Now, what do they ask most of the time in the exam? What they ask is actually okay, before I tell you what they ask most of the time in the exam, so now you already know that you just need to do echo. If you check the patient, you won't see any other thing causing it. You are just like, Mama, you are having, let me check you. Lymphadenopathy is not there. This one is not there. Liver function test is normal. This one, what is now causing your stuff? Oh, maybe the pregnancy, peripartum, and it's going to be around the peripartum time. So, if the patient is in failure, just treat as congestive heart failure normally. You can avoid the teratogens, then use diuretic. If the patient is diuretics, beta blockers or hydralazine, because normally we give patient hydralazine anyways in pregnancy. So if the patient is intrapartum, so then you can be doing echo, usually biannually. All right, sorry. So biannually, like twice in a year. So please never forget this echo, because they will just put it in the question and be like, what the following best next step? The patient is okay, and they like just the echocardiogram biannually. That's what I mean. All the option. That's just the answer. Now, this is the thickest one. This is the most tested concept in the exam. This one they put here. Avoid future pregnancy if persistent ejection fraction less than 50. So if the ejection fraction is less than 50, they will come. The patient will have been treated and like developed. Now the patient is now coming now, want to have another pregnancy. What do you want to tell the patient? Please, if possible, avoid it. Once you see the ejection fraction is less, because it will become worsened when the pregnancy stage, the patient might not make it. So please watch out for this. Like you are expecting question in it. You can be like, so I put some summary here. Left ventricular ejection fraction less than 0.45. Other potential causes need to be excluded. Then treatment if the patient is stable. What do you want to give? This patient is basically stable, but left ventricular ejection fraction is reduced. Oxygen, diuretic, anticoagulant, then vaginal delivery at term. So, but this patient is not stable. Urgent cesarean delivery, go and deliver, or else that patient will decompensate and die. Because when they are during delivery, the patient will not even be able, the heart cannot even cope with the stress of delivery. The next thing you see is the patient is dead. So if the patient is unstable, just go and do CS, JJ. Don't go and be doing permutation and combination for the patient. Any advice? Contraception, please, don't get pregnant. Please, for now, don't do it. This future pregnancy possibility, they ask it a lot. Because the patient will have been treated. Don't forget that the patient will have been treated by possibly a specialist. You are a general physician. You are seeing the patient. You now see it. This is what they want you to remember. Avoid the future pregnancy if at all the left ventricular ejection fraction is less than 0.5. All right, just want to avoid. So when you see this, you will be like, I know what to tell this patient. Not that if you are a general physician, do you think they will bring a patient to you? Who is going to do that with this kind of complicated pregnancy? They would rather push it to those that will handle it. But when they are done, they will push the patient back to you. They won't be seeing the patient forever. So, but you need to know the advice you are going to give to the patient. That's why this is very important, that you don't want to joke with it. Madam, when next can me and my husband now do what we did before? Be like, oh, madam, I actually appreciate that question, but you see, for now, according to the last echo that you did, your left ventricular ejection fraction is still less than 0.5. So it is better you do not get pregnant for now. It's better you do not get pregnant for now, because the outcome may be disastrous, and that's peripartum. Takotsubo. We actually thought when people were shouting, "You broke my heart! You broke my heart!" We thought they were joking, but they were actually joking because the heart can be broken. And what will cause the breaking of the heart is actually severe psychological stress. The same severe psychological stress that many people were shouting, "It broke my heart, it broke my heart," the same thing is here. This patient recently had, what do they call it? Relationship break. How did they put it? Is it break up? Just break up. We did now see the patient now develop these symptoms, that one, and the like that. You can peg on. Okay, so you'll be thinking more towards Takotsubo. This patient recently lost the loved ones. You'll be thinking towards Takotsubo, something related to severe psychological stress without coronary artery disease. So what does that mean? The only thing you will see that will come out in that question is severe psychological stress. Severe. See this. 65-year-old woman is brought to the emergency department due to chest pain. The patient has had intermittent pressure like mid-sternal chest pain since this morning. She has also had mild nausea. Medical history is significant for hypertension. The patient recently underwent screening colonoscopy, and yesterday she was told she has early stage colon cancer. Doctor, her mother died of stroke at the age of 70. She has no medication allergy. Blood pressure is 145/90. Pulse is 101. Oxygen saturation is 99. The chest is clear to auscultation. No heart sound, no heart murmur. ECG reveals sinus tachycardia with deep symmetric T-wave infarction. The patient is taken to cardiac catheterization lab, and coronary angiography shows no obstructive coronary artery disease. Madam, Dr. Lagbaja, have you done that stuff? You say, chief, we did it. We didn't see anything there, but the symptoms and signs look like coronary artery disease. Just go and sit down with the woman. If you watched House, the way they used to do, just go and be like, give me 5 minutes. Madam, what happened recently? You'll be like, doctor, actually I lost my job, and that has been, the house has been, I've been passing through a stressful life. My husband also just left me. No, madam, it's all right. Take handkerchief, you can clear your eyes. You just leave. The diagnosis, Takotsubo cardiomyopathy. So if you go to echo, this is what you will see. They can put it in the question too, this echo finding. So you are going to see this, what do you call it? Apical ballooning. It's apical balloony. So you call it broken heart syndrome. So, and that is how the question will come. So just look at the story, put all manner of things you want to put there. Just put them in between. You just realize that you can easily say whether it's Takotsubo or not Takotsubo, and that's that. So the symptoms and signs will look like coronary artery disease, but when they check, they can't see anything there. So you'll be thinking more towards, hope I'm not dealing with Takotsubo cardiomyopathy. Let me give us a break. So this coronary artery disease, is coronary artery disease now a big deal that we don't you don't know? So we actually know it. Another name is ischemic heart disease or atherosclerotic heart disease. So these are just the names anyway. So how will the patient present? They can present with angina, shortness of breath, dyspnea, exertion, and the likes. These are the risk factor. I usually call this risk factor hyperlipidemia, SHAMAD, something like that. So hyperlipidemia, smoking, hypertension, the age, abdominal obesity, is male sex. Then another here there, abdominal obesity or age. Then D there is DM, diabetic. So S, smoking. So just family history of hyperlipidemia, SHAMAD. So that's how I used to call it. Family history of so a family history, hyperlipidemia, SHAMAD, smoking, and the likes. All right, so that's just by the way. Major risk factor for coronary artery disease include advanced age, male, increased LDL, reduced HDL, hypertension, family history, smoking. MI in menstruating women is very rare. So please don't go and be making a diagnosis that is not common. So what of angina pectoris? So this is how the question will come. I want you to get the gist of it, like get the gist. So a patient will develop symptoms for this angina pectoris when there is stenosis of the coronary artery, usually greater than 70%. So in the exam, you must not joke with this percentage of occlusion. Is when it's greater than 70% that it becomes symptomatic. If it's less than 70% or 70% and below, it's not going to cause anything. So you can be sure that since the patient is coming with symptoms, then the occlusion you have in the coronary vessel is actually more than 70%. And what is that thing that is causing the occlusion? Atheroma. The same atheroma we were talking about, the formation in step 1. Yes, the same thing is what is causing it. All right, so this is just the basic thing. All these other ones, just ignore them. You don't really need them. So how will the patient now present? They usually present with chest pain. You just come with chest pain. You call it substernal chest pain. That's what they will present with. So the chest pain can now be typical or atypical chest pain. So you talk about typical chest pain if the patient is having the chest pain, is provoked by stress or exertion or exercise, and is relieved by rest. You can see the three of them. There is chest pain, which is substernal, is provoked by stress or exertion or exercise, and is relieved by rest or nitrate. You call it typical chest pain. The three of them need to be there. So if you now have the patient is having chest pain, which is substernal, is not provoked by by stress or exertion, and the question is saying the chest pain is relieved by rest or something. So it's a typical chest pain. So you are not really so sure the kind of chest pain you are dealing with. So that's just about the chest pain. So you must note, when do you say the chest pain is typical? When these three attributes must be there. When do you say it is atypical? Not the three of them are there. So how will I now know this chest pain that this patient is shouting of? How will I know it's actually from angina pectoris or acute coronary syndrome? Duration. So it will tell you in the question that the patient has been having the chest pain for like maybe 5 minutes, 2 minutes, 7 minutes. They will just give you something like that. So you just know that for it to be very short, within 2 to 10 minutes, you are most likely dealing with angina pectoris. So if it's now between 10 and 30 minutes, you are most likely dealing with acute coronary syndrome. Where will the pain radiate to? The same place you have known before. The neck, the arm, and it may be associated with shortness of breath, nausea, vomiting, diaphoresis, all those stuffs can be there. So that's just the way the patient describe the pain. It can be described as dull, squeezing. These are the things you will see in question. Tightness or pressure like. So like someone serving. So never forget, like someone sitting on the patient's chest. So pressure like. May God not allow us to experience the pain in Jesus' name. Amen. So but that's actually how they have it. So now, which key facts do you want to note here? Chest pain that is sharp or stabbing, or chest pain that changes with position or breathing or touch is less likely to be ischemic. So all these is changing with position. Maybe I'm dealing with angina. That's wrong. It has nothing to do with position here. Nope, it's not positional. So how do you now want to make the diagnosis? This is the time we are now shouting ECG, ECG, ECG. All those cardiomyopathy, heart failure, and now echo. Here is ECG. So we have come to the ECG realm. ECG. So that's the best initial test. So it is going to be normal anyway in angina pectoris. So however, you may see ST depression, flat or infarcted T-wave changes, or signs of past MI. So what is that sign of past MI you will see on ECG? Can someone remind us? Sign of past MI. I mentioned it right from the beginning. I was shy. I almost even used my anus to talk to myself.
I'll be Q wave.
Q wave. So you just see the Q wave, just be like, wow, past MI, Q wave. So that's what you will see there. Then the next thing that will follow is cardiac enzyme. So which for this is going to be normal. So you see the rest, you can just look at them and be like, yeah, I've seen you, basically. So because the pain is going to be quite typical. All right. So there is something we call stress testing. So I just want you to have an idea that there is something called stress testing. I will show you how you go about it. Exercise or pharmacologic stress testing, so just to detect the inducible myocardia. Don't worry, I'll show you now. Ischemia. So now this is it. Look at this table. There is a way you reason it out. There's a way you reason it out. We have what we call the pretest probability of coronary artery disease. Dr. Ekweme?
Please, you said that the pain will be typical. In which condition?
No, I just say it's going to be, the pain will be typical. Typical that I'm talking about is actually the nature of the pain. Substernal chest pain, not that the pain is changing with position, this and like, no. So it's just going to be either squeezing, substernal, or all those kind of descriptions. So that's when you know that you are most likely dealing with angina pectoris. Do you get my point? Yes. So yes. Now look at this area now. They will test you in the exam. This table. Yeah. They will test it though. Like, just get the gist. It's very easy to look. So and you will be happy that you understand. So you call it pretest probability of coronary artery disease. If USMLE want to help very well, the question will just go and now say the pretest probability of coronary artery disease in this patient is low. Whatsoever they might have talked about, you don't do any other test again. You just say reassure. You know, for someone to come to you and it's like, I'm having this. Doctor, are you sure something is not wrong with my heart? The question now say the pretest probability of coronary artery disease in the patient is low. What is the best next step? Nothing. Reassure. no test. You don't do any other thing again. Yeah, you may pursue other possibility. Maybe you are dealing with costochondritis and any other stuff. But for coronary artery disease, there is no test you want to do that related to it again. The question says, patient is having this, that. Now say the pretest probability of coronary artery disease. They might not even put coronary artery disease. They just pretest probability is actually very, very high. Here, once you see it, it shows that also you don't need to do any other investigation again. This is coronary artery disease. Just go and start treatment. That's high. And so your answer will be to just be looking for something that you is related to treatment. Just treat coronary artery disease. Just start the treatment. Whichever drug you want to give to the patient, you just start it straight. The pretest probability here, this patient having chest pain, this one, blah blah. The pretest probability is intermediate. Once they mention intermediate, you are not sure. Is it the one? Is it not the one? Is it the one? Is it not the one? At that moment, that is when you will do those little, let me just put them under the canopy of investigation. Can you do exercise? The patient is saying, yes, I can do it. Then you ask the patient to do exercise. It is at that moment you ask the patient to do exercise. So, not that you will just read the question and say, go and do exercise. No, never fall for that trap. It is when the pretest probability is intermediate that you do all those things you've learned before. Exercise, pharmacology stress test, this one stress test. All this low, nothing. High, you don't do any stress test here. So once the question mentioned is high, don't go for any stress test. There is nothing you are stressed. They've already said this is most likely going to be coronary artery disease. You still say you want to go and check if it's the one. Then you are doubting the question. You don't doubt them. You see, if it's intermediate, you do it. So can you do exercise? He's saying, yes, the patient can do exercise. You now do the exercise. So stress test, just for you to see if at all the ECG changes can be induced in the patients. You will now be able to see whatsoever that if the symptoms is going to come up again and the likes. All right. So if the patient says, I cannot do exercise, what you will use is what you call pharmacologic stress tests. So see the difference between the pharmacologic and the stress, the exercise-induced stress test, anyhow you want to look at it. All right. So if the patient can do exercise, you use exercise. If the patient cannot do it, you just use pharmacology. What are the drugs? Dobutamine or dipyridamole? Dr. Henke. Someone is raising hand.
Hello, yes. I want to find out this pretest probability.
Yes.
Is it possible that in a question they may give a percentage rather than say that the pretest probability is intermediate or pretest probability is low? Is it possible they give?
You wanted to say a number, right?
Yes.
Yes, I will show you the number. I just want you to first of all have an idea about it. So we'll look at it.
All right. Thank you.
We'll look at it. So the patient can you exercise? Oh yeah, go and exercise. So you now check if at all the symptoms is becoming more prominent or not. So if it's becoming more prominent during the exercise, so whether or you are seeing some ECG changes during the exercise, coronary angiography straight, this is now going to be the best next step that you will be picking in the answer. You just want your coronary angiography, because you now want to see, because this is the only one that is filled with doubt. This is the only one that is filled with a lot of doubt that you are not sure of. Like, what is this? So just check, can you do exercise? Anyone they shall put there, exercise or no exercise, just check. Are you seeing any changes? He say it's there. Coronary angiography straight. What are they going to see on coronary angiography? Who remembers? What? Atheroma. causing obstruction more than 70%. So that is just this area. I'm coming pretest probability notes. So this is actually, there is a way I'm coming. So I wanted to say number before. I wanted to bring out the one. So now look at this. So this is the percentage Dr. NK was mentioning before. So most time what they do is actually they can give you numbers. So where they are just going to relate it to all those risk factors. Do you get me? Then they can also give you this percentage. So if it's less than 10% low, 20 to 80% intermediate, more than 90% high. Or most time, basically, they will just mention low, intermediate, high, low, intermediate, high, low, intermediate, high. So if I already give you percentage, that's fine. If I don't give you percentage, that's also okay. And you already know what you will see that will give you that this typical chest pain. Atypical will not be all those three. So typical one, substandard chest pain, is becoming more prominent with stress, with exercise, and is relieved with rest. If those three are not there, you say it's atypical. So never forget that. So though I'm not going to advise you to sit down to cram the table, basically just look at it simply. Do you get me? When the question mentioned low probability, you don't need to do anything. It's not likely you are dealing with coronary artery disease. If the probability is high, it's likely you are dealing with coronary artery disease. If it's intermediate, that's the one they will be talking about in all those tests. And if it's percentage they are giving you, please use that. All right, what are the risk factors that you will see in the question? So these are the risk factors. Smoking. I put it as family history of hyperlipidemia, SHAMAD. So family history of coronary artery disease, hyperlipidemia, smoking, hypertension, age, then male, being a male, then abdominal obesity, DM. So just look at it and you will be fine. So when you look at the question, you have an idea. So though what we are doing now, we are not solving question, but I'm already trying to show you how the question is actually most likely going to look. So this is another one. So you can see evaluation of chest pain, pretest probability of coronary artery disease. If it's low, don't go and do any other thing. If it's high, start the pharmacology therapy straight, whatsoever drug you want to. And once you start it, push to the experts. Please take over. This patient has coronary artery disease. If it's intermediate, that's when you start doing, can you exercise? If the patient can exercise, you can use exercise to check if at all there is any induced ECG changes or not. If the patient cannot exercise, pharmacology stress test. So where you can use dipyridamole or what? Dobutamine. That's all. Very easy, straightforward. So, and that's what they are putting here, all these jargons here. Stress test appropriate for what? Diagnosis of coronary artery disease among patients with intermediate pretest probability. This is all you are looking for in that exam. Don't go and be overlooking. Just intermediate. Once they mention it, or they give you all those percentages, just pick it and be like, the next thing you want to do is all those stress tests. But if they say it's high, don't go for, just go and start treatment. If they say it's low, there's nothing you want to do. So you can imagine that you are the doctor on duty. They bring the patient and the patient is coming with the typical symptoms. You now look at those risk factors, they are there. The probability is already high, and that's the number I was talking about. So you just look at it. Do you smoke? You say I smoke. Do you have blood pressure is high? How old are you? You're already more than 45 and you are a male. You check it. Yours is most likely we are dealing with coronary artery disease. That's the number. Just check it. I mean, like a lot of risk factors. And you check the chest pain is typical. Just go and be like, the next thing is just go and start treatment. Just go and start treatment straight. That's the answer. All right. So we'll have practice. Though we are going to do. I will take you through a lot of stuff. just small like that. For those that are still looking at us from afar, like, don't mind them.